Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clearnet serves as a digital partner for this event hosted by Association of Fellow Gynaecologists, Mumbai. And the focus of today's session is RAN Symposium. Now, I would like to invite Dr. Vidya ma'am to proceed with the session. Over to you, ma'am.
Thank you, Swastika. Uh, Good morning to all of our audience, our experts. Today we are having the topic of fetal growth restriction, and we know that RAN Symposium has been doing a great work in the academics for the youngsters. So today, as we begin the session for fetal growth restriction, I first call upon Dr. Nitin Shah, who is the president of AFG. Dr. Nitin.
Yeah, good morning, everyone. At the outset, I would like to welcome all the postgraduate students and all the consultants who have joined this RAN symposia. I am highly impressed by the RAN since my old days when I started AFG and before that, where we had a physical meeting in Cooper. And this phenomena of teaching to the postgraduate students had been the legacy of AFG, started by these 4-5 stalwarts, Dr. Mohan Gadam sir, Rajkumar Shah sir, Karthik sir, and Manohar sir. So I welcome you all, sir, and I think you all are doing a fantastic job in shaping the life of the young budding gynecologist by giving them an immense in-depth knowledge about the subject. And today we are going to discuss on a fetal growth restriction. Even our past RAN recordings are there on the YouTube channel. If some students want to visit a past topic, I think it's available on the AFG YouTube channel, which you can visit anytime. Okay, thank you very much. And I hand over Vidya back to you for this fantastic RAN symposium.
Yeah. Thank you, Dr. Nitin. Thank you for your great encouraging words to all the postgraduate students. And yes, we have all our recordings.
I think Vidya is log out probably.
Yeah.
So without wasting time, I think we'll just start with the first talk. Vidya, madam, you're back.
It's in mute.
Vidya, Dr. Vidya. I think then we can start with the first case presentation. Uh, who is presenting now?
Vidya, are you there?
Yeah, I'm there, sir.
Yeah.
Can you hear me, sir?
Yeah.
Sorry for the glitch. Yeah, so we will call upon Dr. Poonam Raiskar. She is a student of the KB Baba Hospital, and we have our very own AFG senior experts, Dr. Mohan Gadam, Dr. Rajkumar Shah, Dr. Karthikeyan, Dr. Manohar Motwani, Dr. Aram Sarogi, Dr. Sheetal, and unfortunately, Dr. Geeta is not there with us, but I'm sure we will be having her recording for us. So, Dr. Poonam, can you just begin the case?
Yes, ma'am. Good morning, respected sir and ma'am. I will start my case presentation. Um, can you share the screen? I have sent to Gadam sir the presentation one, ma'am.
No, you have your own presentation with you, right?
Yes, sir.
You share your screen.
Off कर दो वो.
Mm. I'm not able to share, sir.
Swastika should be able to help. Swastika, can you help?
Poonam,
Yes,
do
ma'am.
I see there is share screen? Just go on the share screen. No, it will be very easy.
There's a green icon. There's a green icon. Is your presentation on your laptop?
Yes, sir. I'm reading from laptop and
Yeah, so now you go on share screen. There's a green icon down there.
Ma'am, you have to come back on Zoom, and then there is there is an icon where share is written.
Okay, just a second.
Can you? Are you able to do it?
Yes, sir. Yes, I'm trying.
Yeah. Give. Yeah. Let us know what you are doing, so we'll just give you some tips.
Yes, sir.
Ma'am, also, if you want any help, you can come back on Zoom and press on share, and you can share the entire screen so that we can guide you, ma'am.
Actually, I started my call on mobile and was reading from one
Okay,
laptop.
ma'am. Okay, that is the reason. Actually, if you would have joined from the laptop, that would have been better, ma'am.
Yes.
On phone, it'll be difficult to do.
Mm.
Poonam, parallelly join on the laptop.
Yes,
Or
ma'am.
if she can WhatsApp it to Swastika, she'll be able to do it.
Yes.
Send it on WhatsApp to Swastika.
Okay, so I'm sharing my number in the chat box. Please send me through that.
Okay.
Mohan, in the meantime, why don't you give a little resume of RAN, because people will be just waiting for this to show you. Mohan, can you hear me?
Yeah.
Why don't you
Manoj?
just, why don't you give some input of yours by the time we get on with the presentation? Something about the topic, something about RAN, something about your organization, because we may have a new set of students who must have joined, a new set of consultants, because otherwise it'll take a couple of minutes for us to start the presentation anyway.
Or we can do the next
Yeah,
day.
okay. And I'll just try to help her out first.
Karthik, the mess up will be, late FGR and early FGR. I think the sequence is important.
Yeah. Yeah, Mohan, talk about RAN. Otherwise, Manor, you talk.
Mohan, the RAN, you talk about the RAN. Mohan is busy with something there.
No, I
Sir,
want
I
to
think
help her out.
Dr. Dadam will be busy. Dr. Manohar, I think you should give us a complete overview of RAN.
I think, okay. RAN, RAN, started from the word RN Cooper Hospital with A standing for AFG. This was the brainchild of a few people, you can call a handful of people. Dr. Mohan Gadam, Dr. Saraugi, who started all this in Mohan's personal hospital, that's his own nursing home. And then they realized there's a lot more to do for the student community. They came together, they thought about it. We had a conference, we had our symposia at various places. We started with Nanavati Hospital. That lasted for a few years. Then we realized that it was difficult to conduct. Logistics came into play. We shifted to Cooper Hospital. That also went very well. Then COVID struck. And after COVID, we had this change of mindset that we should go digital. It helps us to go across the country, let students across the country. Plus, we can have experts across. So that is the reason we are now almost 99.9% digital. And there's no plan to be physical in the future too. And we have these seminars conducted monthly or bi-monthly. Are you ready, Poonam?
Yes, sir.
Okay, then go for it.
You ready? It's uploaded?
Yes, sir, I have received it.
Yeah, okay. Now share the
I'm
screen.
sharing. Yes, I'm doing that.
That's great. Yeah.
So, Poonam ma'am, as I will be sharing the PPT, just command me with next so that I can move to the next slide. Okay.
Yes, yes.
Okay. So I hope the screen is visible to everyone.
Oh, yes.
Yes,
Great,
yes.
great.
And you can start.
Hmm. 20 next slide, please. 24-year-old Mrs. XYZ, married since 3 years, spontaneous, non-consanguineous marriage, Hindu housewife, resident of Dadar, Mumbai, studied till 5th grade, belonging to lower middle class society by modified Kupuswami scale, primigravida with 7 months of amenorrhea, admitted in view of clinical suspicion of lag in fetal growth for safe confinement. There is a history of pain vagina or loss of fetal movement. No complaint of bladder bowel disturbance. No history of generalized weakness, easy fatigability, or breathlessness. No history of fever. Next slide, please. Next slide, please.
Poonam, have you missed something?
Next. Yes, sir.
What is the commonest cause of growth restriction?
Weight loss,
Which
sir.
you have not alluded. Yes, you in the
My,
symptoms you said no history of this, but
yeah,
have you
no history of
signified something
blood.
about pregnancy-induced hypertension, preeclampsia? Have you asked for that? There's nothing. Go back onto the next first slide, please.
Yes, sir. There is no history of blurring of vision, uh,
Yeah. So,
epigastric pain,
okay.
menstrual history. Um, LMP was 27th of December 2024. Past menstrual cycle were regular. By Neglis rule, EDD is 3rd of October 2025 and period of gestation is 28 weeks. Obstetric history. She is married since 5 years with non-consanguineous marriage, spontaneous conception and registered at 4 months of amenorrhea at KB Baba Hospital. In second trimester, this was her first visit at the 15 weeks. She also gives the history of epilepsy since 5 years. On regular treatment, was taking tablet valproate 50 milligram OD from private hospital under physician supervision. Last episode of convulsion was 1 year back. Physician's opinion at Bandra Hospital was sought. Valproate was switched over to levotriacetam 500 milligram BD. She did not have any first trimester investigation, that is blood, urine or sonography. Fortunately, tablet folic acid was taken regularly as per family physician advice. Injection TD first dose was taken in the first visit and was advised hematinics. Couple was counseled and advised for quadruple marker test along with the anomaly scan.
Poonam,
Yes, sir.
yeah, I just want to ask you,
Yes, sir.
what is the significance of dating scan in this case, in your patient, and how important is dating scan, and what are the dating scans? What is the sensitivity at what stage of gestation? Because that's something which is extremely important here, whether you are mistaking the dates.
Yes, sir. In this case, her first visit was 15 weeks, so she has not done any sonography or blood investigation. In sonography dating scan, we have which if patient has missed period and she is pregnant, we do a first scan on the first visit only, and dating scan to be done. That is NT-NB scan.
No.
From
It is different. We are talking about dating, not NT scan. Dating scan is a different scan. At what gestation it is the best time to do? Had she come early?
That is the question.
What
That's the
gestation?
question. She came to you at 15 weeks of gestation. You did the first scan at 15 weeks of gestation, and you found out that she was 15 weeks by sonography. So, how reliable will these be as far as expected date of confinement is concerned?
No, sir, I have asked her about her last menstrual period. Dating scan is important because it gives the exact period of gestation. It can be done to 12 weeks or at the time of registration.
No, beta.
Now,
Suppose
suppose you, Poonam, you do a sonography at 8 weeks, for example, or 7 weeks. Then we do a NT scan at 11 to 13.6, and then we do anomaly scan at 18 to 19 weeks. Which of these three scans are more sensitive as far as expected date of delivery is concerned?
The first cancer is more reliable.
First scan. Yeah,
Yes.
so, what is the sensitivity of a dating scan which is done between 7 to 8 weeks? And is that the most sensitive compared to all other scans which are done at a later stage?
Yes, sir. That's the most sensitive one. There is 95% is the sensitivity.
Okay, we can grant you that is perfect. Earlier you do more sensitivities, later
Yes.
you do 10, the predictive value is plus or minus 6 days, 7 days, 8 days, 10 days also. So
Yes,
a
sir.
scan which is done for the first time at 37 weeks beyond will not give accurate date of confinement. But a scan which is done at 7 to 8 weeks, so that's something very important in your patient because here mistaken date is the commonest factor for diagnosing this kind of an intrauterine fetal growth restriction, right?
Yes, sir.
Yeah,
You're
okay, go ahead.
expecting
Go ahead.
history, and by sonography there is a discrepancy. Which will you give to the patient that this should be the expected due date? Meaning, if your, let's say, LMP by history is giving a date A and sonography at 9 weeks is giving a date B, and there is a discrepancy, which will you tell? Which will you tell the patient that this is accurate or this is accurate?
I will ask her about her.
Go ahead, please. Yeah.
I will ask her about her last menstrual period. Is it a good, excellent, or in poor classification? I will ask her about is it sure of her LMP, last menstrual cycle were regular or not?
Okay. Let's say there is a difference of 7 days. One is saying 1st of July, one is saying 8th of July.
Yes, sir. I
Which
will
will
go with LMP if she
yeah,
is sure
less
of
than
LMP.
7 days, go with the LMP. More than 7 days, go with the ultrasound EDD or
Yes,
LMP. So
yes,
the capital of 7 days. When it is more than that, then you follow the ultrasound LMP because that will help you to judge whether it is a mistaken date or whether it is really a small for gestational age. Go ahead, please.
yes.
Go ahead, Poonam.
Yes.
Next
Then
slide.
no history of
Next
next
slide.
slide, please. By physician opinion at KB Baba Bandra Hospital was sought. Valproate was switched over to levotriacetam 500 mg BD. She did not have any first trimester investigation. Fortunately, tablet folic acid taken regularly as per her family physician advice. Injection TD first dose was taken in first visit. Was advised hematinics and couple was counseled to advise quadruple marker along with anomaly scan. No history of excessive vomiting, bleeding.
Poonam, why was this switch over done?
Because sir, valproate is not safe in pregnancy.
Which category drug is valproate and which category drug is
Levetiracetam.
citriacetam?
Sir, valproate is a category C drug.
Okay. So category C, are they not safe?
No, sir.
What does category C mean?
There is a it has found in the study that there is it is a risk of teratogenic effect in the it is if it is used in the pregnancy, sir.
So category C is not teratogenic effect. That is not category C. What is category C? Okay, Levocet, Levotry. In which category is that drug? Yes. Is that drug category B?
Yes, sir.
It is category B? I am not sure. I'm asking you this question.
Both are C. Both are category C. But basically, there is more reliability on levetiracetam rather than valproate. Valproate has other effects also on the kid and the pregnancy.
So Poonam, both are category C. And they are not teratogenic. Category C means they have been used in human beings, but there is no substantial prospective double-blind trial to confirm that the safety profile of this drug is there in human beings. In animal trials, it has been used and it is reasonably safe, but there are no human trials. But it has been found to be used in human beings and found to be reasonably safe. So there are many drugs which will fall in category C. There are very few drugs which will fall in category B and A, and there are few drugs which will fall in category D. But maximum number of drugs will fall in category C. So both are category C. Remember? Okay, fine. You can go ahead. So they have found levotriazam, cetazam is more safer than valproate because valproate lot more complications and then not found to be very the side effects are slightly more and hence it is not used. But they're not found to be teratogenic.
Yes,
Okay.
If I'm permitted to add, actually, I'm Dr. Monkar, sorry, please excuse me. But basically, when you use valproate, the incidence of neural tube defects is much higher. So shifting to levetiracetam was really a good option.
But that was later in pregnancy.
Right.
Okay, fine. That's important for us to know.
Yes.
Yeah, go ahead, Poonam.
There is no history of yes. There is no history of excessive vomiting, bleeding per vaginum, abdominal pain, fever with rash, radiation exposure, or any other drug intake. Next slide, please.
Poonam,
Second trimester.
Poonam, anything else? Since you're suspecting you have been given this reference of a lag of growth, anything else in history which you think is important about? You said no, this thing, anything else specifically as of course nowadays? Smoking?
Yes, sir. I have asked her in personal history, sir.
Achha, okay. I want to take in personal history. Go ahead. Yeah. Okay, go ahead.
Second trimester, second visit is at a 20, it was at a 20 weeks. Weakening felt at fifth month, not as she was not affording markers. She has done anomaly scan and blood urine investigation was within normal limit. Second dose of injection TD was given. She was lost to follow up for 2 months, reported in 7 months, and iron calcium tablets was taken regularly. Weight gain of 4 kg and no complaints till date. Next slide, please. Personal history. She consumes mixed diet with good appetite, adequate calories and proteins. Sleep with adequate sleep of 8 hours in the night and 1 hour in afternoon. No bowel bladder habits. No history of allergy or addiction. Next slide, please. Past history. She is a known case of epilepsy since 5 years. No contributory significant past or family history noted. Next slide, please. Um, on general examination, she is conscious, comfortable, well oriented to time, place, and person. Her height is 164 centimeter. Weight is 54 kg. That is taken on the first visit with BMI of 18.5 kg per meter square. General condition fair and afebrile. Her pulse is 86 per minute, regular, good volume, no pulse deficit, no radiofemoral delay. Her blood pressure is 110 by 70 mm of Hg, taken in right upper limb in supine position with respiratory rate of 20 per minute. There is no pallor icterus clubbing, cyanosis, lymphadenopathy or edema. There is no midline neck swelling. Next slide, please. Next slide, please.
Swastika.
Ma'am, do I have to move to the next slide?
Yeah,
Yes,
go
yes.
ahead.
Yes, okay, thank you.
Systemic examination. Um, CVS RS was within normal limits. Both breast shows physiological signs of pregnancy. Next slide, please. On per abdomen examination, inspection, abdomen is uniformly longitudinally distended. Umbilicus is flat in midline with overlying skin showing evidence of linea nigra and stria gravidarum. There is no dilated veins, scars, sinuses, and hernial orifice were normal. Next slide, please. On palpation, there was no organomegaly. By Bartholomew rule of 4, symphyzofundal height correspond to 24 weeks, fundal height correspond to 24 weeks, and symphyzofundal height was 24 centimeter, which was is 4 weeks less than the period of gestation, with abdominal girth of 75 centimeter. On fundal grip, it was soft, broad, non-palatable mass was present, suggestive of breech. On lateral grip, uniform, hard, broad like curve resistance felt on the left side, suggestive of fetal back. Small, irregular, multiple knob-like structures were felt on the right side, suggestive of fetal limbs. On first pelvic grip, hard, round, ballotable part was felt, suggestive of fetal head. And on second pelvic grip, both hand fingers converging, suggestive of floating head. Clinically, like mildly diminished. Yes, sir.
Punam, is this the order that you really describe abdominal examination findings?
Um, yes.
Is this the order which is followed?
Um, yes, sir.
I don't think so. Leopold's maneuver. What is maneuver 1? 1, 2, 3, 4.
Sir, fundal. First, we take a fundal grip, then second lateral grip, then first pelvic and second pelvic grip.
I think lateral grip is maneuver 3 and 4. Fundal height, fundal palpation is first grip, second is pelvic palpation. That is Leopold's maneuver 1 and 2, one, or you can say A and B.
Yes, sir.
So
Okay, sir.
if it is fixed, then you go ahead with 2. If it is already floating, then you go ahead with only 1. You don't describe the second one. And then Leopold maneuver 3 and 4 is right and left lateral palpation. This is how usually, not that it will really make a difference, but there is somebody who can ask you this question.
Okay, sir.
That you are arbitrarily examining. So I don't know what is the situation now in medical colleges, whether you go ahead with this or you follow this.
But Poonam, at 24 weeks, do you think you can discuss the Leopold maneuvers? The baby is too small at this juncture, and and it is changing position. So I don't think you should be describing Leopold maneuvers and the discussion. You just say the fetal parts fell. You'll be able to feel a small fetal head. You'll be able to feel the baby. But I don't think you can feel the different parts of the baby the way you described.
Yeah, that's right.
Yes, sir.
Yeah,
I
but
don't
even in
think
the
you
later
should
stage.
discuss it before 28 weeks.
Yes, sir.
Okay, go ahead.
I think gestation-wise, she was 28 weeks, but
Okay.
growth-wise, it was 24 weeks.
Okay.
What
Okay.
she mentioned, yeah.
Yes, sir. Clinically, lichen mildly diminished and fetal parts could be felt easily with appreciated fetal movement while palpating. Uterus was relaxed. Next slide, please. On auscultation, fetal heart sound heard on the left spino-umbilical line at 140 beats per minute with regular, and PV examination was not done and it was not indicated. Next slide, please. In summary, a 24-year-old Mrs. XYZ, married since 2 years, priming gravida, 28 weeks of gestation, known case of epilepsy since 5 years. Valproate was switched over to levotriacetam since 15 weeks of gestation. With normal anomaly scan and non-availability of anti-NB scan or other blood investigation in first trimester, with adequate maternal nutrition, with approximate weight gain of 4 kg, singleton intrauterine pregnancy corresponding to 24 weeks, and symphyzofundal height of 24 centimeter with lag of 4 kg was noted, with cephalic presentation, vertex being presenting part, with regular fetal heart sound, mild oligohydramnias, not in labor. Next slide, please. With provisional diagnosis of 24-year-old primary gravida, 28 weeks of gestation with singleton pregnancy in longitudinal lie, with diagnosis of early fetal growth retardation with mild oligohydramnias.
Poonam, with this diagnosis, one thing is very, very clear that you don't know what is early onset or what is FGR. Your diagnosis should be small for gestational age. You cannot diagnose FGR on clinical examination. This should be a small for gestational age. You're straight away giving a diagnosis of early. When you get the definitions and all, as the topic progresses, you'll realize the goof up you cannot make a mention like this. You have to just say it's a small for gestation age or a small for date baby. That's all you can tell clinically. Is it that you can diagnose FGR? What is FGR as compared to SGA? Do you know that?
FGR is yes, sir. FGR is confirmed after a Doppler. If there is a
How can you
Doppler
give a
changes,
clinical examination? You said I have a suspicion of small for gestational age. The baby is small for the gestational age. That's it.
yes.
Because this is where, as I pounce, any other examiner can pounce on you. Am I
Yes.
right? The fetal
Yes,
medical
sir.
examiner. Go ahead.
Yes, sir, absolutely. Like you cannot make a differentiate between the two without Doppler.
Go ahead.
Yes, sir.
You can just give as a suspicion, can't give it as diagnosis.
Yes, so I'm done with presentation. Yes, sir.
Why are you saying that this is small for gestational age, even if it is? She came to you at 15 weeks of gestation.
Yes.
First scan was done at 15 weeks.
Yes, sir.
That time she was 15 weeks of gestation.
Yes, that was normal.
Second scan is showing 24 weeks of gestation.
Yes. No, that's sir. Anomaly scan was done, which was normal. Then she reported at
Okay.
28 weeks with lag of
Okay.
4 weeks.
And the interval growth is normal, it's matching.
No, sir. After 20 weeks, she reported after 2 months at 28 weeks. At that time, her 4 weeks lag was noted.
Compared to 15 week scan or date.
Compared to that, sir.
Compared to her LMP or compared to 15 week scan?
Compared to her LMP.
LMP. So
Yes.
LMP, how will LMP be important? What is the lag between 15 week scan and 24 week scan? Is there any lag?
No, sir. Clinically, I have suspicion of lag.
No,
There was no.
no, clinically, so such a crude method to really diagnose something. But you have a 15 week scan, you have a 24 week scan, right?
20 week scan.
Okay, you have 20 week scan. Is there any discrepancy between 15 week scan and a 20 week scan?
No, sir.
So it is matching.
Yes.
So these babies growing well.
Yes.
So if suppose at 20 week scan and 24 week scan, another scan is being done, and again the dates are matching. So again the baby is uh, growing well. Doppler is normal. That's why otherwise she'll go into different category by itself.
Yes.
So why are you saying that this is symmetrical IUGR or
Uh,
small for gestational age?
But sir, her last visit was at 20 weeks with normal anomaly scan. Then after 2 months, she has reported, and
That's
in
okay.
between that, she has not
Weight
done
gain
any
is there.
sonography.
But she's reported weight gain is there, fundalite is gone up. Scan is showing 24 weeks.
No, sir, there is no scan of 24 weeks.
No, you will do a scan, no, now.
Oh, yeah.
So Poonam, what you are saying is that you did a scan at 15 weeks, then you did a scan at 20 weeks, which were matching. And then at 28 weeks, when she came, you found that the uterus was small and
Yes.
you asked for an ultrasound, right?
Yes, yes, sir.
That's right. Yeah.
So at 28 weeks, your diagnosis is intrauterine pregnancy less than the period of gestation.
Yes, sir.
All right. Go ahead.
And what ultrasound report
I'm
showing?
done with presentation.
Okay. And when will you call it SGA, small for gestational age, by definition?
SGA, small for gestational, is the if the baby weight is less than 10th percentile, then we'll call for small for gestation age.
Okay. Is there any grading in that? 10th and 20th percentile?
Yes, I know about 10th percentile.
Okay. Okay, 10th percentile. Or clinically the lag beyond how many weeks of gestation?
More than 3.
3 or 4?
2 to 3 is normal. So if 2 to 3, then we will not call her as a SGA. But if there is more than 3, then we will consider as a SGA.
So these babies fitting into both the parameters to call it SGA?
Yes, sir.
It is fitting. Okay.
Yes.
So we have made a diagnosis of small for gestational age.
Yes.
And what is the stage of gestation now?
Sorry, sir.
Gestational age is how much now? 27 weeks.
28 weeks are gestational age, but clinically
28
she is
weeks.
24 weeks.
And clinically and by scan, she is less than 25 weeks.
Have you done an ultrasound, Poonam? What are the
Yes, sir.
findings? What are the findings? Please let us know so we can at least get the discussion from there.
Yes,
What?
sir. On ultrasound,
Yeah.
there was absent end-diastolic flow on the umbilical artery was noted.
The growth parameters before that.
Sorry, sir. On the growth parameter, a fetal biometry was done, in which abdominal circumference, head circumference, about abdominal circumference was within normal limit. Estimated fetal weight was
AC was normal. Just AC was normal at 28 weeks in this patient.
AC, no sir, head circumference upon abdominal circumference, the ratio is normal, but
Okay.
both are decreased.
So where does your thing fall on the chart? Did you follow that growth chart of yours, or it was just written on the paper, or do you people do by growth charts?
No sir, we do by diagnose it by sonography.
So at 28 weeks, you got a patient who's got a lag on the abdominal circumference. What centile was the abdominal circumference? What centile was the expected fetal weight?
Expected fetal weight expected fetal weight was less than 10 centile, and abdominal circumference was also less than 10 centile, sir.
Okay. And what was the Doppler study showing, you said? Absent end diastole at 28 weeks
Yes.
in the umbilicals.
Yes, sir.
Does it fit into it? I don't know. Have you really had this case, or you have made up this case? Honestly, please.
No, sir, I made up this case, sir.
Then let's make it 10 centile and absent end diastolic flow, no underlying factors, no hypertension, nothing else, no renal disease, no medical condition to explain this kind of a thing. It straight away falls onto your face, my dear. If you say that is a hypothetical case, we can understand. But because I saw you hesitating when you say absent end diastolic flow, your examiner will jump out of his chair when he hears this. How can it happen? So how will you monitor?
Yes.
Let's take your patient of hypertension. You got absent end diastolic flow at 28 weeks. How will you monitor her? And how will you deliver her? Just give me this answer, and then we can say quits.
Yes, sir.
She has got an
We
absent
will do
baby weight is 800 grams. Now you tell me. How will you
we will do
how,
her
how will you do a Dopplers or NSTs or whatever monitoring? How will you do? I've taken care of the
fetal
hypertension.
monitoring will be done. Yes, sir.
Sorry?
We will do by bi-weekly sonography. Fetal monitoring will be done bi-weekly.
Absent end diastolic flow.
Injection.
Yes.
Yes. Bi-weekly sonography to be done. Patient should be hospitalized. Then should I sir tell the management?
Beta, you're doing bi-weekly sonographies. You're looking out for what now? What is the next vessel you will track? You're looking at your absent and diastolic flow. What will be tracking on the Doppler? What will be tackling? Will you give her something else in case of a preterm delivery? Is there
Yes,
any
sir.
added you will
Injection
give?
corticosteroid will be given.
What and how
Corticosteroid will
much?
be given.
What and how much?
Betamethasone,
And how often?
betamethasone 12 milligram 24 hours apart, or dexamethasone. Uh, so dexamethasone, betamethasone can be given or dexamethasone can be given, and we will do bi-weekly ultrasound monitoring, and we will try to extend the pregnancy. We will try to conserve the pregnancy till 34
Bi-weekly means once in 2 weeks?
Twice in a week, sir.
Twice weekly.
Twice week.
And
Twice
and
in a
you
week.
you want to continue to 34 weeks.
Raj,
Yeah.
but the sonography is showing absent end diastolic, right?
Yeah, but how you want to plan to go to 34 weeks with absent and diastolic flow?
Is the last scan showing absent end diastolic?
The 28 week scan. Is
It's showing absent end diastolic.
Yeah,
let's
we have made a case now. She has made a case. I've given her a case of PH having end diastolic flow at 28. She's saying bi-weekly we'll be doing the Doppler studies. And now she's got a reverse flow. Come on, after a week, 29 weeks, reverse flow.
29 weeks reverse flow. We will do her daily fetal heart sound, daily monitoring, sir. Daily sonography to be done. And we after completion of the corticosteroid dose, we should terminate pregnancy at 30 weeks.
My dear, she's already getting a ductus pulsating out there. Waiting. We wait for another week and kill that baby rather than get the baby out. Internal environment is better, the outer environment is better for the baby. You're given
Outer
steroid since
yes.
the last dose. She's got an absent flow. Would you want for the ductus to show its signs in this
No,
case?
sir.
Then how will you deliver? Will you do a delivery? No, this thing normal delivery. Will you try on her?
No, sir. In that we will do immediate termination after completion of corticosteroid dose.
Discuss with the patient, discuss with the neonatologist, have an NICU ready, have a tertiary care center ready, and only then take a decision where to deliver.
Yes, sir.
Whenever you make a hypothetical case, see that you just close all the ends before the case becomes very obvious, and don't. This is all something which you straight away says, I didn't have a case, I'm making an hypothetical case.
Yes.
Now tell me, what is the difference between SGA and FGR when you define? Just one question for you. What is FGR and what is SGA?
FGR, fetal growth restriction, it is divided in two types, early and late. If
How will
growth,
I say that this particular baby has got FGR? She's SGA, definitely. All FGRs are SGAs? One important question. Are all FGRs SGAs?
uh, no, yes, sir, or
No.
FGR or SGA.
No. Late FGRs may not have an SGA, please. That I will discuss when it comes to that. So it becomes your centile comes into play. So with Doppler problems coming up, structural defects coming up in the baby, you'll require now this SG has become an FGR.
Yes.
So all SGAs are not FGRs. Is that right?
Yes, sir.
Are all SGAs FGRs?
No, no, no.
Similarly,
All
all
FGR.
FGRs are not SGAs. Is the answer is again is no, no.
Yes, sir.
You have a falling centile from 70th to 25th centile in late FGR and still become the patient will not be called SGA. The weight may be within normal limits, but you may have a late this thing FGR coming up. So weight may not become a parameter in FGRs, especially in late FGRs. So this is a misconception. Don't carry late FGRs. When we discuss, we'll come to that. But for early FGRs, if the suppose the weight is less than third centile, Dopplers are normal. Will you call it FGR? Third centile weight. Will you call it FGR? Dopplers are normal. Dopplers are normal. Will you call it FGR? Less than
No,
third centile. Dopplers are normal. Third centile. Doctor's telling me 2.9 centile. Dopplers normal. Will you call it FGR? Or will you call
no,
it
sir.
SGA? You will call it FGR.
SGA.
That's a definition. When we come to Delphi consensus, you'll realize that. My dear
Sorry,
girl, it is an important topic for exams, important in practice. Read the right books.
yes, sir. If estimated fetal weight or abdominal circumference is less than third percentile, then we call it as a FGR.
So that's the definition of FGR. Less than 10 with Doppler abnormalities in either of the vessels or third centile becomes FGR. Others become SGA.
Yes, sir.
Clear?
Yes, sir.
Sure. I think let's take the next. If Mohan agrees, let's go to the next case.
Yeah. Okay, sir. Thank you, Dr. Poonam, and all our experts. I think it was a very good case discussion and a good take-home message for all the postgraduate students regarding the early FGR. Now we have Dr. Madhavi Baheti. Dr. Madhavi, are you around?
Yes, ma'am.
Are you ready with your case?
Yes, ma'am.
Okay. Will you share your screen?
Yes, ma'am. I will just start sharing this.
Yeah. Dr. Madhavi, just introduce yourself. You are from which?
My screen is visible, ma'am.
No, not yet. Yeah. Yeah. Now it is visible. Yes. So, Dr. Madhavi, yeah, get to your screen. She is from Faith GS Medical College and KEM Hospital. She is going to be taking our second case on asymmetrical fetal growth restriction. Okay, over to you, Dr. Poonam.
Okay. Okay. I will start with the case, presenting the second case on fetal growth restriction. Going forward with the case, my patient, she is a 30-year-old married female, married for 2 years in a non-consensuous marriage, a primary gravida, postgraduate, accounted by profession, belonging to a lower middle socioeconomic class with 8 months of menorrhea. Patient's last menstrual period was on 15th of October 2024. Her expected date of delivery is 22 of August 2025, corresponding to 36 plus 2 weeks of gestation by date. By scan of 10 weeks, patient was corresponding to 36 weeks of gestation. Patient came for routine antenatal checkup, was referred from maternity home in view of intrauterine growth restriction with recently diagnosed hypertensive disorder of pregnancy. No complaints of pain in abdomen, leaking per vaginum, bleeding per vaginum. No complaints of headache, epigastric pain, vomiting, blood vision. No complaints of decreased fetal movements. For going forward with present pregnancy history, in first trimester, it is a spontaneous conception confirmed with the home urinary pregnancy test and viability scan. Patient was on tablet folic acid 0.4 milligram in first trimester. NT&B scan and dual marker tests were done. The results were within normal limit. There was no history of any fever, rash, or bleeding per vaginum in the first trimester. In second trimester, patient was started on hematinics and calcium. Anomaly scan done at 19 weeks of gestation. No abnormality detected. Estimated fetal weight in the scan was corresponding to 60 centiles with normal uterine artery PI. Quickening was felt at 20 weeks of gestation. Patient has received 2 doses of injection tetanus. In our third trimester, patient's visit was there at 30 weeks of gestation. Scan done at 30 weeks of gestation, and that estimated fetal weight was corresponding to 50 centiles. Menstrual history, menarche was achieved at the age of 13 years. Previous cycles were regular. Menstruated every 28 days for 3 to 4 days. There is no history of menorrhagia or dysmenorrhea. In past history, there is no significant past history of diabetes, hypertension, tuberculosis, asthma, epilepsy, thyroid disorder. No significant family history. In personal history, diet was mixed diet. Appetite was maintained. No history of any addictions or substance abuse. General examination, patient was fair, patient is conscious, moderately built, weight of 60 kg, height of 162 centimeter, BMI corresponding to 22.8 kg per meter square. Pulse of 88 beats per minute, BP 130 by 80 millimeter of mercury in right arm in left lateral position, urine albumin nil, respiratory rate 16 cycles per minute, SpO2 maintained. There was no paler, icterus, clubbing, cyanosis, edema, lymphadenopathy, no premonitory symptoms. Cardiovascular system, S1, S2 heard, no murmurs. Respiratory system, was bilaterally equal. Breast examination was normal. On inspection, generalized distension of abdomen with linea nigra and stria gravidarum present. Umbilicus flat, no scar, sinuses or dilated veins. On palpation, uterus was 32 weeks size, symphysiofundal height of 32 centimeter, longitudinal eye, no uterine contractions perceived. In Leopold's maneuver, fundal grip, broad, irregular, non-palatable part, likely to be breached. On lateral grip, smooth, continuous structure on maternal right, suggestive of fetal back, and irregular knob-like structures on maternal left, suggestive of fetal limbs. Pollic grip, which is pelvic grip first, in that smooth, hard, palatable mass was felt, highly likely to be fetal head. On pelvic grip 2, hands converging, suggestive of non-engagement. On auscultation, fetal heart sound was heard on maternal right, 144 beats per minute. Post speculum examination, os was closed, no show, no altered discharge. On vaginal examination, os closed and effaced, no show, no leak. My provisional diagnosis will be 30-year-old primary gravida with 36 plus 2 weeks of gestation by date, with singleton live fetus and cephalic presentation, small for gestational age, not in labor.
So what size of the fetus you think it is clinically 36-week gestation wise, and clinically what is your fundal height suggesting?
Sir, clinically the fundal height was suggestive of 32 weeks of gestation.
So the lag is you think more than 4 weeks?
Yes, sir.
And up to 32 weeks, her distinct findings were normal, clinical findings.
Yes, so the patient was referred to us, but on her paper, it was suggested that it was corresponding. 30 weeks was her last visit at the maternity home. Until that time.
That time you said that the sonography at the time was how much? 60th centile. No, that was earlier.
Yes, so 60 centile was on anomaly scan, and then it was 50 centile at the 30 weeks of gestation.
How much was it you said?
So 60 centile at anomaly scan, and the repeat sonography at 30 weeks of gestation, it was corresponding to 50 centiles, estimated fetal weight.
And have you done the last scan?
Yes, sir. After the patient was referred to us, we repeated a scan, and that estimated fetal weight came out to be 2.9 centiles. And in the Doppler
2.9 centile at 36.
Sorry, yes, sir.
Okay, so there is a dip of how much you said, from 50th centile to 2.9 centile?
Yes, sir.
Almost 2 quartiles.
Yes, sir.
Okay. And what is the expected baby weight now at 36 point some weeks?
So the estimated fetal weight came out to be 1.8 kg, which was less than 3rd centile.
Would you call it FGR?
Yes, yes. So since the estimated fetal weight and abdominal circumference were less than third centile, and there were also changes in the CPR ratio. So I would like to call it as
Can you tell me the difference between early FGR and late FGR?
So in early FGR, firstly, there is a difference in the period of gestation at which it has been diagnosed. Early FGR, 32 weeks, it is diagnosed if it is before 32 weeks of gestation, and late is after 32 weeks of gestation. In early FGR, the estimated fetal weight or the abdominal circumference is less than third centile. Or if abdominal circumference or estimated fetal weight is less than 10 centile with any of the changes in uterine artery PI more than 95 centile, or umbilical artery PI is more than 95 centile. While in the case of the late FGR, it will be diagnosed after 32 weeks of gestation with estimated fetal weight or abdominal circumference.
Some connectivity issue.
Dr. Poonam?
Hello,
Dr.
yes.
Madhavi. Yeah, Dr. Madhavi. Okay, carry on.
Lost you at
Yeah.
second point, I think. Yeah.
Yeah. Okay, continue.
Okay. Sir, in late FGR, it is diagnosed after 32 weeks of gestation. The abdominal circumference or estimated fetal weight will be less than third centile, or estimated fetal weight or abdominal circumference will be less than 10 centile with any of the above, which is either there is more than 2 quartile difference in the interval growth, or there is CPR ratio is less than 1 or less than 5 centile, or umbilical artery PI more than 95 centile.
That's a definition, but what are the other differences between early and late? Placental pathology, where it is more, where it is less.
Sir, in early FGR, generally we see a symmetrical growth restriction, while in the late it's an asymmetrical. In early FGR, there can be a maternal cause, there can be fetal cause, there can be placental cause. In late FGR, we generally, it has been seen that there is a uteroplacental insufficiency. Early FGR, if we send a placenta for histopathology report also, in that there are changes which are seen generally in the form of infarction or thrombosis of the vessels, while in the late FGR, there is mostly the problem is with the diffusion through the placenta.
And the placenta is more affected in early FGR than in late
Yes.
FGR.
Yes,
Right.
yes.
And let's come to hypoxia. Which of the two fetuses are more hypoxic? Early
Sir,
FGR is more hypoxic or the late FGR is more hypoxic?
sir, early FGR is more hypoxic since there
And
is a
who's
damage.
less tolerant to hypoxia? The early FGR is less tolerant or the late FGR is less tolerant to hypoxia?
Sir, late FGR is less tolerant to hypoxia since
Late
adaptability is
FGR
there
has
in
got
early
less
FGR.
tolerance to hypoxia. Hence, we see a lot of stillbirths coming in late FGRs.
Late FGR is the problem with early FGR is with the management, while in the late FGR, the problem is the detection. If it is the detection of a late FGR is where there is a
Now
problem.
she's 36.2 weeks. How will you proceed with her?
So the patient came to me at 36 plus 2 weeks of gestation. So I will offer her an admission first of all. Secondly, I will do a non-stress test for this patient to see if whether it's reassuring or not reassuring. If it comes out to be reassuring, I will do a Doppler for her, admit her, do a daily fetal movement count if Doppler parameters are within normal limit. If everything is within normal limit, I will try to terminate the pregnancy at 37 weeks of gestation.
What Doppler vessels do you study in late FGR? In Doppler?
So the most important is our middle cerebral artery Doppler and the CPR ratio. So that's the most important in late FGR because the changes will be seen in middle cerebral artery. So thereby, if it's less than fifth centile, our CPR ratio is less than 1, then.
So before you go on to the Dopplers, what are the sonographic parameters where you will suspect? You said abdominal circumference and other things which could be affected, no question about it. But are there any biophysical parameters that you'll be looking at?
So the biophysical profile.
NST gets affected much later.
Yes. So the biophysical profile we will be doing for this patient, which has 4 components. We will be looking at the amniotic fluid volume. We will be looking at the fetal tone, fetal movement, and fetal breathing.
I think. Yeah. Go ahead, say again. Madhvi, say it again.
Madhvi, can you repeat?
Yes, ma'am.
Yeah. So you said amniotic fluid volume and then?
Sir, amniotic fluid volume, there will be fetal, we will look at the fetal breathing, fetal movement, and fetal tone. So
in which order does the affection start? Supposing the baby is getting compromised. Yes. What happens first and what happens last?
Sir, the amniotic fluid volume will be affected. Then there will be affection in the fetal respiratory movement, and then fetal tone will be affected at the last.
Yeah, that's good. So now if you have a report from, a sonologist who's saying that fetal movements are less, but the amniotic fluid volume is good, would it match?
Yes, sir, it can
Just
still
remember
be...
this. Yes, so this is not a right report, if you understand that.
Yes, sir, it is not
so
a
you
right.
should try and understand the sequence in which it happens and then give credence to that report, right?
Yes, yes.
And then, of course, you talk about Dopplers. Yes.
Yes.
So
nowadays on they don't some of them talk about AFIs. Now two separate sonologists will give you two separate AFIs on the same patient at the same time. So now they talk about the deep vertical pocket. How much is that?
Deep vertical pocket, yes.
Yeah. So now can you get a normal Leica with an abnormal Doppler? And vice versa.
Sir.
See, these are questions we are asking our experts. There are cases the Leica may be absolutely normal, but you have a poor CPR. And there are cases having a normal Doppler Leica showing AF of 5.
Yes.
So these are questions which are not getting from the experts ourselves. So these are maybe they are there somewhere in the air, but still I have not got the answer to it. Where the Leica may show 3, but the Dopplers are normal. So we are at an end at what we should do. Should we, how do we terminate her? Should we induce her or not? Or should we take her for a section? That's how the thing is. So at 37 weeks, you want to draw a line in her. How will you terminate this pregnancy?
So at 37 weeks.
The ratio is 0.9.
Yes. So sir, at 37 weeks at CPR ratio of 0.9, firstly, I would like to counsel the patient along with their relatives. I will explain both with, what is the risk associated, risk and benefits associated with cesarean section and with the labor progression. If my non-reassuring stress test comes out to be reactive, then we can give her a trial of labor. But given that, we have to be very vigilant in our intrapartum fetal monitoring. If we
is there anything called as OCT?
Yes,
Oxytocin challenge test.
Yes, sir. Oxytocin challenge test. Yes, sir.
So
yes, sir. In that, sir, in oxytocin challenge test, we give 5 international unit of oxytocin. It has been the basic idea of the test is we will induce pain in the patient and look at the CT, NST changes. If there are changes along with like late decelerations or any changes have been seen, then in this case, there are high chances of fetal distress. So it's better to give them a cesarean section rather than going for the trial of labor for them.
Yeah. And inducibility of the cervix, you never mentioned about that. You said.
Yes, sir. Also, we will look at the Bishop score of the, if the Bishop score is less than 3, then it's a poor Bishop score. So first we will need to prime the cervix. Priming needs to be done, and which will again, it has been seen that the medical management for the priming, if we use, it will again lead to more distress in the fetus, who is already compromised.
Okay. Now, during labor, yeah, good. Manu, go ahead.
These fetuses are very, very prone to hypoxia. You may have a sudden intrapartum stillbirth. So if it comes to a little doubt, it's better to vary out and get off with a planned section or an emergency section rather than give a trial for all this. Because we've always seen you may have a sudden deterioration and the baby goes there. And these are very, very smart fetuses. They can go off in no time. Late FGR is something. So many stillbirths you analyze, you'll find that this baby was an undetected FGR. That is how it is. So these are those demons in the dark which you can't see, but they come like without any expectation. Anyway, I think you've done very, very well. You've read the topic beautifully well. This is the first thing which I got when you started talking. Any questions from anybody else? Ajay, just since you're doing so well now, this is for the gold. What is the 30-70?
Sorry, sir.
What is the 30 to 70 concept? Gold,
Sir, I'm
gold.
not.
I'll tell you. See,
Is
we
it
talk about
like
placental
placental?
pathology.
Sir,
Yeah,
yes,
go ahead.
placental pathology, sir. So, in umbilical artery Doppler, if there is a uterine artery, umbilical artery PI more than 95 centile, then it said that 30% of the placenta has been affected. If it's absent end diastolic flow, then 50% of the placenta has been affected. If it's reverse end diastolic flow, 70% of the placenta is affected, sir.
So we'll give you the gold.
Okay, I think Dr. Madhvi, you really deserve the gold, and
I mean,
it
the way you
is
started
all
your
coming
presentation,
from Dr. Manohar.
I mean, let's not try to degrade any institution, but KM still holds the cake.
Okay, sir.
I
So
think
thank you, Dr. Madhvi.
Dr. Madhvi and Poonam both made an effort to present, and I think that is
Absolutely.
commendable. We should encourage more students to come in and present cases. This is like an examination, like a mimic, sort of a mock examination. And I think more students should come forward to present cases. This is, the sheer guts is important in presenting the cases. The authenticity, of course, will be tested by our examiners, no question about it. But
And I
thank you very
think,
much.
Dr. Rajkumar Shah, you said it very clearly. And I think students should not get scared of making mistakes. Because if you make mistakes, you're going to learn from this platform. And that is what we want. So more and more students should come forward and get more knowledge from this platform. So I thank both the students, Dr. Poonam and Dr. Madhvi. Thank you very much. The cases were very brilliant and very well presented. And I thank all our experts for taking their time every now and then for RAN Symposium and actually upgrading it every time. So thank you, everybody. Now we move on to the speakers. Our first speaker is Dr. Geeta Belsarkar. Unfortunately, Madam is not able to join us, but we have her video recording. Swastika,
Yes, ma'am, I'm playing it on the screen.
yeah, can you share
Yes,
her
ma'am.
video?
I hope my screen is visible to everyone.
Yeah, it is. It is.
Hello, friends. I'm going to speak to you today fetal growth restriction. And me this particular opportunity to speak in front of you.
Is the screen got stopped, ma'am?
Yeah, the slide sharing is not happening. The recording has stopped also.
Okay, I'm resharing it on.
Just reshare it again, Swastika.
Or referred to us with fetal growth restriction. So what is fetal growth restriction? Intrauterine growth restriction describes a decrease in fetal growth rate that prevents an infant from obtaining his or her complete growth potential. IUGR infants are small for gestational age if their birth weight measures less than 3% to 10% using the standard growth curves. Less commonly, these infants may be characterized as appropriate for gestational age or AGA babies if their growth restriction is mild. However, it is important to distinguish between infants who experience in utero, but they are constitutionally small. That is, there is no loss of percentile throughout gestation. Since IUGR fetuses undergo fetal adaptations to almost resulting in a pathologic condition, leading to distinct short and long-term outcomes. An AGA fetus or an constitutionally small SGA fetus, they are normal fetus and they have normal growth potential even outside the uterus. So if we see that there is specific distinction between symmetric and asymmetric IUGRs, if we see the incidence, symmetric IUGR is between 20 to 30%, whereas 70 to 80% of are asymmetric IUGRs. If you see the period of growth restriction, symmetric IUGRs begins very early, in the first or the second trimester, but asymmetric IUGR is a late onset IUGR and begins in the third trimester. If we see the physical changes, it's got a small, heavy is small in all parameters. In asymmetric IUGR, they have a large head size but a small abdomen because the fat deposition in the liver is restricted. Therefore, their abdominal girth is very small. So the pathophysiology is there is impaired cellular embryonic division and impaired cellular hyperplasia and hypertrophy in symmetric IUGR, whereas in asymmetric IUGR, there is decrease in the cell size. Etiology, asymmetric IUGR is mostly intrinsic. Chromosomal abnormalities and many congenital malformations have to be taken into account. There could be the reasons of drugs, infection, early onset severe preeclampsia, preeclampsia less than 30 weeks superimposed with chronic hypertension. But asymmetric IUGR is mostly extrinsic. The placental and maternal vascular factors or the placental insufficiency is a cause of asymmetric IUGR. The outcome in symmetric IUGR is greater morbidity and mortality, but in asymmetric, we have to be very, very vigilant, and we should be able to diagnose an asymmetric IUGR as early as possible. Otherwise, IUFD can happen even in these patients. So if we see the maternal factors like chronic non-communicable diseases like hypertension, chronic kidney diseases, autoimmune diseases, preeclampsia, genetic predisposition like the TNF alpha, ESR1, MTHFR gene variants, chronic malnutrition in the mother, any chronic drug use in the mother. If we see the fetal factors, the genetic abnormalities, the chromosomal aberration like T13, T17, 38018, the Cry-Du-Chat syndrome, monogenic disorders like the Noonan syndrome, abnormal methylation, intrauterine infections like torch infection, and in multiple pregnancies, there'll be selective IUGR. The placental factors is inadequate spiral artery remodeling, genetic mutations in the mother, structural abnormalities of the placenta like biloplacenta, endoinsertion placenta, and placental tumors like chorioangioma. All this could lead to fetal growth restriction. So if it can be roughly divided into maternal, placental, and fetal, we have seen more of these, but here I found some more maternal problems like collagen vascular diseases, hypercoagulable states, thrombophilia, anti-phospholipid antibody syndrome, persistent hypoxia like in high altitude pulmonary or cardiac disease, severe anemia, undernutrition, toxins like tobacco irradiation, and uterine malformation or masses. These could also cause, among the placental causes, abnormal trophoblast invasion, placental infarcts, placenta previa, circumvallate placenta, filamentous umbilical cord insertion, and umbilical placental vascular anomalies. And in the fetal, genetic is there like about 20%, chromosomal abnormalities, syndromes, multiple gestation 5%, intrauterine infections like cytomegalovirus, malaria, parvovirus, rubella, toxoplasmosis, herpes, HIV, all could add to fetal growth restriction. So the multifactorial causes of IUGR, they create three possible scenarios. One is the abnormal placental function. That is the basis for all fetal growth restriction. There has to be an abnormal placental function. But this abnormal placental function, an inadequate supply of oxygen and or nutrients added to that, or the decreased ability of the fetus to use these supply. These are the three main causes or scenarios in which we can have fetal growth restriction. The placenta plays an integral role in the first two categories: abnormal development, inadequate perfusion, dysfunction of the placental villi. They are responsible for the development of IUGR, especially the early onset type. But insulin and insulin-like growth factors like IGF-1 and IGF-2 are the primary anabolic hormones necessary for fetal growth, and it is postulated that they may play a critical role in the development of IUGR. Therefore, if there is deficiency of IGF-1, IGF-2, it could be one of the fetal factor that is responsible for the formation of the FGR. So coming to the chromosomal abnormalities, we have already discussed most of that: trisomy 13, 17, 18, Cradle-Chatt syndrome, William-Buren syndrome, or the monogenic syndromes, which could be responsible for the fetal growth restriction. So these are the whole lot of genes, and these are all the variants that can be seen of the genotype that leads to FGR, or the severe preeclampsia in the mother, leading to the growth restriction in the baby. So TNF-alpha, ESR1, MTHFR, FLT1, PAL1, MMP9, TGF-beta1, NPHS1, ERAP1, ENOS, IL-32. These are the various genes that have been implicated in the formation of IUGR in the baby. So coming to the actual problem, what it is, there is reduced placental VDR expression. Because of this reduced placental VDR expression, there is increased trophoblast differentiation, that is increased beta HCG release and syncytialization, that could lead to increased trophoblast apoptosis. So increased TP53 and decreased TGF beta 3 expression. So all of this could lead to placental insufficiency, leading to FGR. So there is deficiency on remodeling of the arterioles, placental hypoxia, ischemia, and cytokines imbalance, and endothelial function. So combination of all these leads to a preeclampsia in the mother as well as a FGR in the baby. The effects of preeclampsia in the mother are very severe. She can have cerebral visual disorders, pulmonary edema, liver function, renal insufficiency. All these could be seen. So there is a relationship between vitamin D, TLR4 pathway, and the preeclampsia. So they say vitamin D deficiency also could be implicated in the formation of preeclampsia and impaired trophoblast invasion. So it can cause ischemia and hypoxia in the uteroplacental compartment, oxidative stress leading to inflammation and pathological angiogenesis, endometrium destruction, coagulation system activation, and a clinical manifestation of IUGR with hypertension, preeclampsia, HELP syndrome, abruptio placentae, and fetal death. So now there is a newer theory in fetal growth restriction. They say that the mother's heart is very, very important to begin with, and an altered cardiac function before pregnancy, or even a normal or a subnormal cardiac function before pregnancy, it can lead to an abnormal placentation and early onset fetal restriction of growth and preeclampsia. So now the entire focus is shifted to the mother's cardiac status, and they say the mother's cardiac status is primarily important in determining the development of growth restriction and preeclampsia. So now this is for the early onset FGR. What about the late onset FGR? Actually, the mother's heart could have been healthy or asymptomatic state of low cardiac reserve. In the first trimester, some initial hemodynamic changes are happening, while as it progresses to the second trimester, it becomes like a stress test to the mother. The heart is now getting decompensated, and in the third trimester, because of high increase in placental request, it causes a late onset IUGR because of altered maturation of the placental vessels and impaired fetal growth. So the entire hypothesis is that now the mother's heart is responsible for the formation of fetal growth restriction and IUGR. So I'm sorry for the busy slide, but this slide tells us that the abnormal systemic and or vascular local inflammatory state that is responsible for affecting whether the growth restriction is, if it is of high grade, early onset FGR, or it could be mild, late onset FGR, or it could be late onset FGR that we normally see, which can be picked up on the color Doppler. So if we see the placental insufficiency, maternal low protein diet, maternal calorie restriction, maternal glucocorticoid exposure, maternal diabetes, all that causes fetal adaptation in the to the intrauterine environment. This adaptation of the fetus to this difficult intrauterine environment that causes permanent structural and functional changes in the organs and tissues of the fetus. So if the pancreas is affected, there is decreased beta cell mass, there is decreased beta cell muscle insulin secretion, predisposing the fetus at a later stage to early onset diabetes. If there is liver is affected, there is increased gluconeogenesis. If skeletal muscle is affected, there is decreased skeletal muscle mass, decreased insulin sensitivity, and increased lipid oxidation. If it is adipose tissue, it causes decreased insulin inhibition of lipolysis, and insulin stimulated glucose uptake is decreased. As the baby ages, it can become an obese adult with impaired glucose tolerance, type 2 insulin resistance, and diabetes. So there are a lot of effects and ramifications of IUGR. So the maternal, placental, and fetal factors that they have seen, all in all, it leads to inadequate maternal supply, decreased ability of the fetus to utilize supply, and abnormal placentation, which leads to the IUGR or the FGR. Then there are metabolic, hormonal, and vascular changes, altered gene expression and molecular pathways, alteration of the cell, tissue, and the organ growth, imbalance of the cell types, decrease in cell number, all the while this fetus is adapting to the hostile intrauterine environment, which leads to the perinatal effects like perinatal and neonatal mortality, perinatal depression, hypoglycemia, hypothermia, prematurity, RDS, necrotizing enterocolitis, intraventricular hemorrhage, and hypothyroxemia, and various infections. In the childhood, as this particular FGR child grows, it can cause poor growth, some neurological sequelae, and in adult it can lead to hypertension, type 2 diabetes, and coronary artery disease. So this is very, very important to keep these screening these IUGR and FGR babies till much later in life. So to conclude, regulation of fetal growth is multifactorial and complex. Diverse factors, including intrinsic fetal conditions as well as maternal and environmental factors, can lead to the FGR. The interaction of these factors governs the partitioning of the nutrients and the rate of the fetal cellular proliferation and maturation. Although FGR is probably the physiologic adaptive response to various stimuli, it is associated with distinct short and long-term morbidities. Immediate morbidities include those associated with prematurity and inadequate nutrient reserve, while childhood morbidities relate to impaired maturation and disrupted organ development. So thank you for a very patient hearing.
Thank you, Dr. Geeta. I think her recording was very well portraying the fetal growth restriction, early and the late onset. Now we go to Dr. Sheetal, who's going to take the management of the FGR. Dr. Sheetal, are you around?
Yes, yes, I'm very mature.
Yeah. Welcome, Dr. Sheetal. Thank you so much for accepting our invitation and always being there for RAN Symposium. I give you the platform now. It's all yours. Thank you so much.
Thank you. Thank you. So at the outset, sir, can you see
Sheetal
my
is a
screen?
fetal medicine consultant.
Okay.
Yeah.
She's come out of President Institute Mediscan by S. Suresh. She's done multiple fellowships in Canada in fetal medicine at the Mount Sinai and Sick Kids Hospital. And she's spread all over the town doing scans in multiple centers. And nowadays, if you look at FGR, we thought that we were the people who call shots, but now it is the fetal medicine people who call shots. So the person in charge, Sheetal, all yours.
Yes, thank you. So at the outset, I'd like to say that it's a huge privilege being invited for AFG, and I also consider it a very huge responsibility because I realize that a lot of our audience is students who will probably take whatever I say, my word, on face value. So I do not present what I do very lightly. It's a very well and special appreciation for AFG. I remember when I was a resident, the only time we used to get to even present cases were when we were exam going. And at that point in time, not having done a good presentation would really break your morale. Whereas AFG gives you the platform to do it one Sunday every month. So I would say students should really take this up and start presenting cases very earlier on from your residency and not wait like how we had during exams. Second, what I'm going to say is going to be quite, I'm going to make a few statements that are quite contrary to what our usual practice has been. There are certain concepts which I would want everybody to just completely get rid of. It's not easy, but it's not something that I'm saying. It's something that a lot of data has been saying, and probably accepting it would improve a lot of our outcomes. So I begin with a typical scan report that you see quite often, where you get a report like this, where they've said that the Liker is normal, placenta is anterior, the growth parameters are mentioned, the weight is mentioned, and the EDD is mentioned. This is probably like a regular growth scan that everybody that gets done in the early third trimester. So my question is, are we happy with this report? I mean, does this report really tell me anything except for telling me this is the estimated weight of the baby at this point in time? So are we really happy? Do we think that this report is complete? At least what's the very basic information that is missing from this report? I would say the basic information that's missing from this report is we just know how much the baby is weighing, which is the weight. What we don't know is how old the baby is, which is the age. So the one thing that I would urge everybody to disconnect today onwards is to start using gestational age, to not use gestational age and weight or growth interchangeably. 27 weeks by gestation by LMP is how old the baby is. If the weight of the baby is corresponding, is like say 600 grams, and by scan corresponding to 24 weeks, saying that the baby is 24 weeks gives a very wrong idea. It's not making the baby 24 weeks. It is just telling you that the growth is that much lesser. So again, on the other hand, expressing growth by lags of week, 3-week lag is IUGR, 2-week lag is IUGR. My question then becomes, 3-week lag at 30 weeks. Do you think it's the same as a 3-week lag at 34 weeks? And what if the lag is 3 weeks and 3 days? Are you going to call it IUGR, or the lag is 2 weeks and 6 days? So again, these weeks business is all for aging. And to really make matters, IUGR is a very complicated condition to manage in the first place. To make it less complicated, I think we should all just give up mentioning weeks in growth and just stick to centiles. The only time when those weeks might matter is when we are doing our fundal height measurement, sure. But beyond that, once you have a scan report and once you're reporting IUGR, the only thing that should come out of our mind, of our mouth and in our minds is centiles. So let's shift from using weeks to defining growth in terms of centiles. So if you see, there are many conundrums in FGR. It's not a very clear-cut topic. There is lots of controversies from the very basics to management. What I've tried to do is kind of wade through them and find very easy to follow simple protocols that we could practice in our day-to-day life. So FGR has a very ambiguous definition. It is defined as failure to achieve its full growth potential. This is very ambiguous. This doesn't really tell me. Each fetus has its potential, and how do we know it's failing to achieve it? Unless we get a chance to follow it up serially. So worldwide, again, when they started describing FGR, there were various cutoffs which were used: less than 3rd centile, less than 5th centile, less than 10th centile. And then there was also a lot of debate still ongoing about what chart should we use. Should we use intergrowth chart, which has a huge series of numbers and multiple ethnicities, or should we use FMF charts? Should we use population specific charts and take into account mother's weight and height, basically her BMI, into this calculation? Or should we use the Hadlock charts, which are the default charts that all ultrasound machines come with, and which, by the way, are the most inaccurate for centiles? For giving the weight, they are okay, but expressing that weight as form of centiles, they are probably the most inaccurate for our population. So there's like a lot of controversy even there, and there's no single chart which everybody approves that, okay, this is what should be used. And then, like Dr. Motwani sir asked, or are all small babies growth restricted? So there is a concept that in babies that are small, there are some that are healthy small for dates versus some who are small because they're not reaching their full potential. And at the same time, are all growth restricted babies necessarily small? So if you define smallness as any baby less than 10 centile, like sir very aptly said, not all growth restricted babies will fall in that sentence, in that less than 10 centile. It's very possible that you have a baby whose weight is at 25 centile at term, which by your definition might not fall into a small baby. But what if the potential of that baby was to grow at 70 centile, 80 centile, and it's only growing at 25 centile? So that's another conundrum. And the only way we might pick up this small subset of cases is if we start doing routine Dopplers for all growth scans at term. Again, something which is controversial, which is not accepted, but one of the things that I'm putting out there for today's discussion. Moving on. So the universally accepted definition of fetal growth restriction is as either an estimated weight or an abdominal circumference, which is less than the 10th centile. This should be the starting point of our investigation right now, as we have it today. The moment we see a report where either of these values are less than 10th centile, we need more information. And this could be at any gestation. This could be right from anomaly scan to later on any gestation. When we see this, what do we do? First and foremost, we confirm the dating by a first trimester scan. It's ideal that we get to do that because the sensitivity or the error is the least when we have a first trimester dating scan. If you don't have a first trimester, we go by the next earliest scan possible. Any scans lesser or after the second trimester and their value for dating becomes very, very questionable. So first we confirm dating. Second, we look at the report. What does the anomaly scan say? Was the detailed anomaly scan normal, or any markers or pointers pointed out at the time of the scan? And once we've done that, third, when we see a weight at less than 10 centile, the report is absolutely incomplete without a Doppler assessment. So if that has happened, you send the patient back and ask for a Doppler assessment, because otherwise we don't know how to go on. All this is important. After we do this, the next step we do is, once we see a weight of less than 10 centile, we try to segregate these babies into the high risk, which is the FGR group, and the intermediate. I will not say low risk, but the intermediate risk, which are the healthy, constitutionally small babies. Then we also try to differentiate whether this is early or late onset FGR. And after that, we try to stage how severe is the FGR, and then we determine the follow-up and the delivery protocol. This is what we're going to go through in the rest of the slides. Now, why is it important to differentiate between FGR and constitutionally healthy small for dates? Finally, if the baby is small, why differentiate? That is because constitutionally small fetus are described to usually have good perinatal outcomes. And so they are considered low risk compared to FGR, or babies who are small because of a smallness of the placenta. FGR, on the other hand, are known to have a slightly increased perinatal morbidity and mortality. So you would probably not want to follow up the SGA babies or the constitutionally small babies or the small for date babies as intensively as the FGR babies. Having said that, we will also not just leave them. These SGA babies or small for date babies also need follow-up, but not as intensive as the FGR babies. Early versus late, we've seen enough discussions here, but the one myth that I would want to bust is, nowadays, calling an FGR or describing an FGR as symmetric or asymmetric is completely obsolete. Earlier thinking was, if the FGR is early onset, it is symmetric, and we're almost always looking at some intrinsic factor. Intrinsic factor means either genetic abnormalities, aneuploidies, one of those syndromes, or some infection. Whereas we always assumed that if the FGR is late onset, it's going to be very asymmetric with an AC lag. And the usual cause for this is almost always placental dysfunction. And now we have enough data, and also I would say in this case, my personal experience, to completely bust the myth. We have seen enough cases of early onset FGR at 16 weeks, 18 weeks, where the culprit is the placenta, which has been proven by multiple things. Either the mother has symptoms, or she's got a past history, or she's already a diagnosed case of APLA, and the placental histopath after that has proven that the placenta was the cause. And amniocentesis done and offered have come out normal. So early onset FGRs could also be because of placental dysfunction. And we've seen cases of late onset FGRs. I have had 2 or 3 cases of Down syndrome where the FGR was late onset, where the lag was not just in the AC, but also in the femur, where the Doppler showed mild high resistance in the umbilical, and where we never suspected this to be Down, but the baby turned to have trisomy 21 after birth. So we should, from our heads, completely forget this concept of symmetric and asymmetric, or that symmetric is always intrinsic and asymmetric is always extrinsic. No, there is a definite overlap. And the only thing now that we look at is it early onset or is it late onset? And take it on from there. Why? Because again, we've had enough discussions here. Early onset ones are the ones where the placenta are more damaged than usual. So they are not the silent kinds. They will shout loudly at you. Either the mother will have preeclampsia, or like how it was described in the first case presentation, very obvious lag in the frontal height. So these are babies that you're not going to miss. The trouble is not that. The problem with these babies is how do we save them? How far can we take them? And that these babies have a very higher chance of systemic cardiovascular adaptation, which means the findings are so severe that it ends up affecting the heart and the contractility of the fetus. And they have a high morbidity and mortality simply because of the prematurity attached to it. The problem with the late onset FGA babies, on the other hand, is that we might not pick them up. Not all of us might have the practice of doing a growth scan at term. In such situations, sometimes if the growth is just at 10 centile, your fundal height might not be a very good parameter to pick up that, okay, the baby is not growing well. And the prevalence of these kind of late onset in comparison is a little higher. Because the placental dysfunction is milder, we will not see preeclampsia. Again, because the placental dysfunction is milder, they might not even come up as red flags in your first trimester preeclampsia screening. They might actually have a low screening. Here, the challenge is the central nervous system. It's not the heart's hypoxia that we are worried about. It's the brainstem's hypoxia that we are worried about. And again, even though they might have low mortality if picked up, but if not picked up, they are still one of the commonest causes of late stillbirth. So the challenge here is picking them up and not management. Now, before we move on to how we stage, I'm going to briefly describe the tools that we use for staging. The tools that we use for staging essentially would be the Dopplers. Few Dopplers are maternal circulation or something that tells us about the placenta. And the other Dopplers is then the way the fetus adapts to those changes. So the commonest and the most important vessel that we use as far as growth restriction is concerned is the umbilical artery. Again, here, there are various ways that this can be used. We basically want to describe the resistance of flow in the umbilical artery. That describes against the, basically, this is a marker of how much is the placenta giving that resistance to the blood flow. So basically, umbilical artery is not really a fetal Doppler in that sense, because it's not telling you about the baby. It's telling you about how bad or how resistant is the placenta against which the blood is flowing. So basically, it's telling you about the placental health. And now, by standard convention, the parameter that we have chosen to use and where all recent FGR papers use is the umbilical artery PI. Gone are the days when we look at S by D, more than 3, less than 3. No, it has to be PI. And this PI has a cutoff. And this cutoff is, again, gestational age dependent. Okay, so umbilical artery PI, like I said, tells us about the placental bed resistance. And there is a very definitive and a very predicted pattern of worsening, where usually it will begin with an increased resistance, move on to absent, and then to reversed end-diastolic flow. The speed with which this happens might differ, especially if there is very severe coexisting preeclampsia, but it does go in a specific pattern. This helps us because then we can know how much time do we have when we have a particular finding, and whether or not, how frequently we need to follow up in case that particular finding is present. That umbilical artery, which is why it's brilliant, because it helps us for follow-up and timing. And hence, it is used for serial monitoring to best improve the perinatal outcome, to plan delivery, and to reduce perinatal mortality as much as possible. When we see an absent or a reverse end-diastolic flow, means there is already chronic hypoxia that is set in. When you see absent end-diastolic flow, the hypoxia is probably of recent onset. A reverse flow tells us that there has been a chronic hypoxia that has already set in. However, there is no need, IUFD usually does not occur, the moment you see an absent flow, especially in a fetus who you have been following up, and slowly that high resistance has become absent. The fetus is not going to have an IUFD in most cases the very next day or even the same day. So just seeing an absent end-diastolic flow or a reversed end-diastolic flow need not be the trigger to deliver. But when we deliver in these babies is, again, we have got enough evidence to see when we can deliver. And usually, even at absent or reverse end-diastolic flow, we usually have those 48 hours to give the 2 shots of steroids and to give Maxelf in these babies. So again, just seeing that finding in itself should not be panicky. It is probably better to wait those 24 hours, give those steroids, and then deliver, than to deliver immediately without steroid cover because we've seen the finding. Next vessel is the middle cerebellar artery. Now, middle cerebral artery is the vessel which is telling us about the cerebral or the central hypoxia. Whenever there is FGR and there is compromised umbilical blood flow, and so the amount of blood flow going, so the fetus adjusts. If it's getting less blood flow and hence less oxygen, it prefers to give increased flow to the heart and brain. Giving increased flow to the heart is giving more blood flow to the brain, means giving more blood flow to the brain than normal, because the oxygen is not enough. So what happens is, normally where the MCA middle cerebral artery should be high resistance. By rule, all arteries with high fetal arteries with high resistance are good except the umbilical, but it's not a fetal artery in the first place. So normal MCA flow, which is high resistance, becomes low resistance because the brain wants more blood flow so that it can get the oxygen to work, which means basically it's an early sign of hypoxia. But the moment I say it's an early sign of hypoxia, again, does not need to trigger any panic. A low CPR, or which means mild hypoxia, does not necessarily translate into, okay, I have to deliver. It does indicate that if you see IUGR babies which have a low CPR, their outcome would be probably poorer than a baby which is not growth restricted. That's a fact. However, what is not clear is whether delivering these babies before term is going to help their case. The fact that the CPR has become low means there is already mild hypoxia. We do not want to add prematurity on addition to that hypoxia and worsen the outcomes. So low CPR, delivery of a fetus with low CPR before term is of unproven benefit in these babies. And why do we talk delivery? Because so far in FGR, especially because of a placental disease, the only thing you can do is to make the baby independent from the placenta and change the source of nutrition. So basically, the only treatment that you can have for FGR is delivery. What we are trying to do here is try to find out a balance where you let the baby be inside the intrauterine environment till a point that being inside becomes unsafe than being outside. It is the possibility that because of extreme prematurity, even because of advanced findings, we still feel it is safer for the baby to be inside than outside. But if we choose that option, we are obviously monitoring the baby, like I will come to in the next few slides. So this artery is of very good value in identifying adverse outcomes, especially in the late FGR. Why do I say late FGR? Because early FGRs don't need MCA to tell you that they are sick. We have enough other arteries doing all those vessels for all those jobs for us. So MCA per se does not weigh in any decision making in early onset FGRs because there are better blood vessels for that. Versus late FGR, where if the placenta is not severely damaged, the umbilical resistance might not be abnormal. And so this is when this artery comes to a rescue. So this is again another myth of mine that was busted when these findings came out. The earlier teaching was if the growth is normal and Leica is normal and umbilical PI is normal, we don't need to worry about MCA. That is no longer true. Even if the umbilical PI is normal, we still need to look at MCA PI because especially in late onset or in term patients, it's a much sensitive indicator for FGR than umbilical alone. And even better than MCI is the ratio of MCI PI upon umbilical PI because that takes into account both. There are times where you might have umbilical, which is at 85 centile, which is still normal. MCA, which is 7 centile, which is still normal. But when we do the ratio, the CPR will fall less than 5 centile, which is abnormal. So the ratio is even more sensitive in picking up these cases than the individual vessel PIs themselves. So this is a very good tool that we have for these late onset cases. Then the only problem is picking it up. So this is very handy, that's why. So here, MCA more than 95th centile or CPR less than 5 centile is how we define it as abnormal by the common consensus. Coming to ductus venosus. Ductus venosus is a vessel which comes into play at a much later stage of the disease process. It is a vessel which tells us about the heart. Like MCA told us about the brain, ductus tells us about the heart. It is the vessel which takes blood from the umbilical vein, all that oxygen-rich blood, and directly takes it to the right atrium in the heart. So it is the vessel which is just before the heart. So any condition where the cardiac contractility is compromised, okay, where the heart does not pump enough, those side effects will be first seen in the ductus venosus vessel. So it becomes abnormal in very severe stages because even in FGR, for the heart to be hypoxic enough for the contractility to be compromised takes time. So, which is why it becomes abnormal in very severe stages of compromise. And the reversal of A wave of the ductus venosus, which is the absolute final stage of DV abnormality, tells you about impending cardiac failure. So this is the vessel which we use as the last ditch attempt at your when you are managing a baby with FGR and your intention is to salvage the baby, which means you think with the NICU setup that you have at your disposal, the current baby is salvageable. Then a change in the ductus venosus is the time when we decide, okay, this is enough and we deliver. So this is the vessel which you look at just before you want to deliver in cases, obviously, where there is severe prematurity. So which is, again, at what stage this comes in useful, we'll see when we look at the stages. So hence, it's the strongest single parameter which will predict the short-term risk of a fetal death in cases of early onset FGR. So which is what, if you see ductus venosus abnormality, when you've already declared that your fetus is viable and you are planning to save or salvage the fetus, this is when you plan a delivery. Ductus venosus changes, again, tend to precede spontaneous decelerations by a good period of 48 to 72 hours. So if for any reason, you've not covered the baby by steroids already, this still gives you some time. Though I would think by the time you see a DV abnormality and the fetus is under monitoring, most of those things would have already been done. But it precedes NST changes before 48 to 72 hours. And the last vessel that you see is the uterine artery Doppler. Uterine artery Doppler, again, it's the PI that we use, a mean PI, not left and right separately, but the mean PI more than the 95th centile is what we define as abnormal. This artery or this vessel has a bigger role in prevention and screening for preeclampsia rather than really management of FGR. The only time it comes in handy is especially to differentiate FGR from SGA. What we mean is, I'll come to it in a while, but if the fetus is less than 10 centile and if the umbilical MCA and DV is normal, but the mean uterine artery is high resistance, that's still one blood vessel which is abnormal, then the fetus will be labeled as FGR and not small footings. So basically, it helps us differentiate that. Once there are abnormal Dopplers in the other vessels, then it just becomes theoretical looking at the uterine. I mean, it's not going to help much other than just proving it's the placental dysfunction which is which is causing all this here. And again, at any point in time, once you first documented that the uterine artery is abnormal, at subsequent follow-up, we don't need to keep checking the vessel because it's not going to be changing in any linear fashion, which will help us in any discussions or in any managements. So once at the very first time when you've seen and suspected an FGR, yes, you do the uterine. Once you've done it, at subsequent follow-ups, we don't need to repeat it. Now, after having discussed what we have at our disposal for making certain decisions, what next we're going to do is we're trying to stage it and try to decide how we're going to follow up these cases. So again, here, there are many guidelines. There is the Barcelona group came up with these guidelines like almost 7 to 8 years ago, which to me were the most unambiguous and very straightforward guidelines to follow. The ISHOG came up with guidelines a few years ago. The difference between the two is the Barcelona guidelines are very much based and all studies done in their population. ISHOG guidelines are not that cut and dried. They give you a range and they take into account that different facilities are available in different parts of the world. Unfortunately, what we lag is guidelines of our own. We do not have any guidelines about how our babies behave. When we follow them up, we do not have guidelines about whether or not these particular guidelines, when applied in our population, work in the same efficient fashion. What also differs in our population is access. Not everybody is going to have access to a tier 3 NICU, which is the only thing which will be able to determine the outcome in cases of severe early onset FGR. So in the absence of very clear-cut Indian guidelines, what I tend to use in my personal practice is the Barcelona guidelines because they are very clear, very unambiguous, and there's no two ways or there's no doubt about, how it should happen and what should we do next. So again, just to look at the checklist, once you see that the weight is less than 10 centile, you go back, you look at the dating, you look at the anatomy, you sort that out. Any issues with dating or anatomy becomes an entirely different thing. If you see any abnormalities on an anomaly scan, then we know we're probably looking at a genetic issue, and the further management might not follow this protocol then. After that, once you have a baby which is less than 10 centile, you see how less than 10 centile. If the baby is 3rd centile or lesser, no giving it any benefit of doubt. You just pick up that baby and call it FGR. We do not give it a benefit of doubt that it could be small for date, mother is small. No. 3rd centile is severely small. So the moment you see a severe smallness, we just pick it up and we call it FGR. After that, we look at the Dopplers. What are the Doppler findings? If there is any single vessel which is abnormal, it will not be called as small for dates, even if that vessel is a uterine artery. Any of the vessels with any abnormal flow and your less than 10 centile immediately becomes an FGR and not an SGA. And then is the 3rd factor of growth velocity. This is a parameter which has been added by Issuer guidelines. We don't see that in the Barcelona guidelines, where decrease in the growth velocity, even when compared to an anomaly scan, it does not have to be a recent growth, but decrease in the centiles of more than 2 quartiles, which means more than a 50 centile difference in the weight or the AC between the anomaly scan and between your current scan is an independent factor which we take into account. If that happens, even if the Doppler is normal, even if the weight is between 3 and 10 centile, we still will call it FGR and not SGA. And then again, depending on when they presented, we will call it early onset or late, with the cutoff being 32 weeks. Having said that, let's say if I see a baby at 33 weeks, and the only scan that that was done was at anomaly, and for whatever reason, lack of follow-up, if at 33 weeks, I'm seeing that there is severe IUGR and there is an absent flow, I'm not going to call it late onset because I've seen it at 33 weeks. I happen to see it at 33 weeks, but the onset of this FGR has definitely been before 32 weeks because I'm seeing an absent flow. So again, when we differentiate between early and late, ideally it's the onset of when these changes occurs and not when you are seeing it for the first time. Also, usually, rule of thumb, late onset FGRs will not have absent flow, because late onset FGRs by definition is where the placenta is not very severely damaged. So even if you take that into consideration, the moment you see an absent flow, you know that this is probably an early onset FGR and not late onset. Even though the way these babies, how they behave matter, the beauty of the protocol that I'm going to describe next is that it doesn't matter after a certain point of what the early and late onset is. How we follow up these babies and when we deliver these babies will only and only depend upon the staging. And that staging is irrespective of whether it is early or late. So there's no confusion in that sense. You don't have to remember different cutoffs for different types of FGRs. So this is the Delphi consensus. Delphi consensus means what Issuer tried to do is they tried to get a bunch of experts who have done a lot of work on FGR to at least try to come together and agree to certain criteria, because FGR has a lot of controversy, like I already said, right? From what should be the cutoff, what chart should be used, what parameters should be used. Should we do Doppler if the growth is normal? Even that is something that's debated. What is the significance of an abnormal MCA when everything else is normal? So there was like a lot of debate there. So this is a Delphi consensus. What this means is this is not proven by evidence, but this is something which experts who have been following FGR for a very long time have come together and agreed that this is the criteria we will be used. So in early onset FGR, if the weight is 3rd centile or if the umbilical is showing absent, there is no way that this is SGA. This has to be directly classified as FGR. It doesn't need any additional findings to call it FGR. But if the AC is less than 10 centile, then along with that, there has to be some Doppler abnormality, either an umbilical which is high resistance or a uterine which is high resistance. Then you can call it FGR. So basically, it's the same thing, just put in a slightly complicated fashion. Why they have not included MCA here is because in early onset FGR, usually the umbilical artery changes will precede the MCA changes. So if you look at this, what it tells you is if the weight is less than 10 centile, then there has to be some Doppler abnormality that you add to it before you call it FGR, or it gets called as small for days. After 32 weeks, which is the late onset category, where the findings might be subtle, here again, the moment you see a baby which is 3rd or less than 3rd centile, it gets called as FGR. We do not call it small for dates, irrespective of the Doppler findings. In the absence of that, any of these findings, 2 out of these findings gets called as FGR. Now, if you see the difference, in 32 weeks, they have not added absent end diastolic flow as diagnostic criteria. It's because, like I said, in late onset FGR, it's extremely unlikely that you're going to have an absent end diastolic flow. So it doesn't make sense adding it in the criteria. So any baby less than third centile or less than 10 centile, either with falling centiles or with a Doppler abnormality. So basically, both these criteria are saying the same thing, but they're just trying to make it specific. Any baby less than third centile, FGR. Any baby between 3 and 10 centile with any Doppler abnormalities, FGR. In late onset cases, additional criteria is also to look at the fall in centiles. If you see that the growth velocity has fallen more than 50 centiles, then that's an independent criteria that you can consider to call it FGR and not small for dates. The idea being that they're really trying to keep the high risk category as broad as possible, because you do not want to miss any FGR, because your follow-up is going to be different from a small for dates baby. So again, just to explain it in a much simpler fashion, any weight less than third centile, between 3 and 10 centile with any Doppler changes is FGR, between 3 and 10 centile with any falling centiles is FGR. Whether it is early or whether it is late, doesn't matter. You just keep it simple. And you label it as small for dates or SDA. Basically, to keep it simply, it's a diagnosis of exclusion. Like, put it in another way, where the weight has to be between 3 and 10, and interval growth has to be maintained, and all the Dopplers have to be normal. So everything has to be okay before you call the baby SGA. Smallest of things that is not okay, and bang, it gets labeled as FGR. And then once we know whether we've called it FGR or SGA, then we try to stage the FGR. There's no staging of small for dates or healthy small for dates babies. They don't follow staging. There's just one category, but we then try to stage the FGR. And this staging applies whether it is early or late. So for a small SGA fetus, you don't still let them be, because there could be a small overlap where these SGA fetuses have a much milder FGR component, which won't get picked up if you don't follow them up. So they do require follow-up. The thing is, you follow them up 2 weekly. Every 2 weeks, you do a growth and Doppler, and every time the criteria should be fulfilled. The growth should be maintained. It should not go less than 10 centile, and Dopplers have to be normal. If it continues to happen from the point of diagnosis till the point of delivery, then with 2 weekly scans, you can deliver till 40 weeks. But we do not go beyond dates. So we avoid post-datism in such babies if everything is fine. And then we go to SDR. What is first stage FGR? A first stage FGR is either a very small baby or a baby with mild placental insufficiency. So weight less than the third centile with normal Dopplers, or third to 10, or any weight which is less than the 10 centile, which has either abnormal uterine artery Dopplers, abnormal umbilical in the form of high resistance flow, or high diastolic in the MCA, or a low CPR. So very early changes in the Doppler or a very small weight. These are the ones which we call as the stage 1 FGR. So the criteria is the umbilical has to be a positive end diastolic flow. Okay, if the umbilical is normal, at least the uterine should be abnormal. So all the others, they're all stage 1. Any small baby with a positive umbilical artery end diastolic flow is stage 1. That is the bottom line. Rest all is just noise. What do we do with the stage 1 FGRs? Unfortunately, we have to follow them up weekly. It is very difficult, I understand, to convince patients to come for a weekly scan. But here, what we need to do is every week, we do not have to do the whole growth and Doppler and everything. Every week, what we can do is we can do AFI and Doppler, that's just Leica and Doppler on alternate days, on alternate weeks, and then we can look at the growth 2 weeks later. That kind of helps save the cost. So we follow it up weekly. If it continues to stay at stage 1, which means if the umbilical artery end diastolic flow continues to stay positive, then we can continue this weekly regime and go till 37 weeks. The moment they become 37 weeks, you deliver. Now, mind you, this is the Barcelona guideline. If you look at Ishok guideline, it gets even more confusing. So I just tend to stick to this, and it has worked well for us in the past few years. So again, any small baby with any Doppler abnormality, as long as the umbilical has a positive end diastolic flow, it is stage 1. So all your low CPRs, high uterines, all of that is stage 1. So see very carefully. Let's say there is a low CPR, high umbilical, low MCA. Still, you follow them up weekly, you take them to term, because yes, low CPR does mean hypoxia, but it is not that bad a hypoxia that you add prematurity to it. Okay, so you follow them weekly. And when I say weekly, it is for, I will be following the baby weekly with Doppler's AFI and 2 weekly with growth. At your end, we will definitely be doing NSTs. We do not have we do not have computerized CTGs here in our country, which is what was used as the additional tool when all these protocols were set. But instead, at least what we can do is NSTs. Even at early gestation, we might not see accelerations, but we will see some beat-to-beat variation. And basically, we will also look out for spontaneous deceleration. So that additional cover of NST has to be there in these cases, along with my Doppler management. And then stage 2. Stage 2 is severe placental insufficiency, where now there is absent end diastolic flow in the umbilical artery. It doesn't matter what's happening to MCA because this is already a low CPR now. Absent end diastolic flow in the umbilical artery, but the ductus venosus is still normal. Okay, these are stage 2 here, which means there is already hypoxia that is setting. What do we do here? In these babies, we follow them up at least twice in a week, maybe even more if there is coexisting preeclampsia. So you follow them up twice in a week. This is the point where you might want to cover them with steroids and Maxelf. And when I say delivery by 34 weeks, if that is the highest that you can go, but anytime between 32 to 34 weeks, you can deliver this absent end diastolic flow. Again, here, what is important is if at 29, 30 weeks, I'm seeing an absent flow, but the ductus venosus is normal, according to data, these babies are okay to be intrauterine for at least another 2 more weeks, provided the patient is compliant and there's going to be a follow-up. Okay, so which is why these protocols are useful. Sometimes it's very, before these protocols, even my decisions used to be very, very knee-jerk in some cases. Like it had always been a conundrum or a question. What if there is absent flow at 28 weeks and the baby is very small? What if the absent flow is at 30 weeks? What if it is at 30? Like, how do we deliver? Now, what this protocol has done is instead of making it arbitrary, it has set up guidelines, which they have a very strong basis to propose. So the maximum you can take them to is 34 weeks, but anytime between 32 and 34 weeks is okay. These are the babies where you might not think of doing an induction at all. More than 50% of inductions end up in an elective cesarean, end up in an emergency cesarean. So stage 2 onwards, delivery by elective cesarean is completely acceptable. What I forgot to mention is stage 1 is by the same via corollary, that those are patients that you can definitely give a trial of labor. Like it was discussed in the second case very beautifully, they need to be monitored. So what they mention is if you are giving trial of labor to a fetus with growth restriction, there has to be continuous NST monitoring or a CTG monitoring during labor, which means a machine has to be strapped to the abdomen and there has to, even if you don't take the printout, there has to be a continuous CTG trace. If you think your setup does not offer that kind of monitoring, if you think it's not possible for you to have that kind of OA, probably it's better not to give an induction, a trial at all, because these babies need to be monitored. Like sir said, the FHR can fall off at any point. So if you are giving a trial of labor for stage 1 FGRs, there has to be continuous NST monitoring during labor. Moving on to stage 3. This is a much more advanced stage of deterioration where the hypoxia that you see in the fetus now is chronic. It's been a while since the hypoxia is set in, but we don't think that there is acidosis yet. Why does it matter? Because acidosis is bad. Once you see acidosis, and if your plan is to deliver, then you deliver. Okay. So in reversed end diastolic flow in the umbilical artery, and or one of the two, the ductus venosus has a high PI. So the resistance is more than the 95th centile. There is no absent or reversed A wave in the ductus yet. But if the ductus is more than the 95th centile or there is reversal of flow in the umbilical artery, then we categorize that at stage 3. These babies at a high risk of stillbirth and poor neurological outcome. That's a given because of the hypoxia. But they are still not at the stage of imminent death because there is no A wave reversal in the ductus venosus. What do we do if these babies are picked up before 30 weeks. So at 28 weeks, 29 weeks, you see FGR. You follow up these by probably daily or alternate day Dopplers. We don't need to do growth. We just need to do daily or alternate day Dopplers. We need to see daily NSTs to look for decelerations. And the moment you reach 30 weeks, you deliver. Why this is important? Like you would say, why would you want that additional headache at 28 weeks when I'm seeing a reverse flow? Why would I want that headache of doing alternate day Dopplers? Why would that? Two reasons. One, because like I said, these changes usually happen in a stepwise fashion. And after a problem in the umbilical, we're looking at the ductus at every time to see if the next changes happen. So it's not as if things generally happen, they skip steps usually. Second, every day that the baby gains intrauterine improves a 2% outcome. There's a 2% improvement in postnatal outcomes for every day that the baby gets to stay in the intrauterine environment. So even 29 weeks and 30 weeks, that 1 week of intrauterine stay of the baby does have a very significant improvement in the outcomes. As far as the cost is concerned, cost of a daily Doppler, a daily NSD is far, far less than a single day of NICU that the baby is going to have to be in at such intensive levels. So whether you say cost, whether you say outcomes, in both those cases, we are kind of justified in waiting, unless, of course, there are other extenuating circumstances like maternal health or maternal blood pressure. That management supersedes everything else. Or if you think that the mother is not going to be compliant or lost to follow-up or something of that sort. But otherwise, from evidence point of view, we can wait till 30 weeks to deliver them. And then moving on to the last or the most severe stage, which is the stage 4 FGR. Here, there is a very high suspicion of acidosis because the DV is now showing A-wave reversal, which means the cardiac contractility has compromised to a certain extent. There is cardiac hypoxia and imminent fetal death. Here, there will be spontaneous, eventually this reversed A-wave reversal will progress into spontaneous decelerations and a loss of short-term variability on a CCTG. Intact survival in these cases is 50% after a 26 weeks gestation. If for whatever reason, while you are preparing to deliver, when you have this finding in while you are preparing to deliver, you can follow up with a 12-hour Doppler and 12-hour NST. And like I said, when we reach stage 4, our decision should be clear. What are we going to, like, how are we going to manage it? If we reach stage 4 at 24 weeks gestation, where the fetal weight is already just hardly 300 or 400 grams, we know that the chances of this outcome of this baby in an NICU, intact outcome is very, very low. Of course, we can get the NICU team on board in this discussion. So here we know that the outcome of a pre-viable fetus at 24 weeks with stage 4 FGR is not going to be satisfactory. In which case, it does not make sense to offer this kind of intensive monitoring and daily NSTs. All this kind of intensive monitoring is only if we have plans to act on those changes. And those plans means plans of delivery. So by the time we reach stage 4, we have to be very clear in our head of what our management of this fetus is going to be. And we would definitely include the neonatal team in this discussion because they have a bigger role to play here than we do. So in the end, the one thing which all experts have agreed on is protocol-based management is the only way to optimize treatment for FGR. Doing arbitrary decisions, taking one decision for a fetus at one gestation and a very different decision at another similar fetus, simply because your past experience has not been very pleasant, or so you become overtly cautious. That happens to all of us. But that is not what this condition demands. It demands a very evidence-based, protocol-based management. Baseline, all cases of FGR should be delivered when they reach top. If it's less than third centile, even if it's just high resistance umbilical, no stage 1 FGR should go beyond 37 weeks. This is as per the Barcelona protocol. If you notice, I have not spoken anything about Liker status in any of these stagings. Be it the issue of staging or the Barcelona staging, they do not include oligohydramnios because, like sir discussed earlier, it is a very unreliable factor. I mean, for obstetricians, like even when I started seeing cases, we strongly react to an AFI of 2, AFI of 3, AFI of 4, and it has its place. I'm not denying it. But as far as these guidelines are concerned, they do not let liker influence their decisions. What the issue of guideline did say, though, is in countries like ours, where we do not have a CCTG, a computerized CTG to monitor these babies, doing an NST and a BPP in addition might improve the pickup or the protocol. So the moment you do a BPP, we do take oligohydramnios into consideration. So adding BPP might help if you do not have a computerized CTG, but otherwise oligo per se in these protocols do not play a role, which is why I kind of rue the absence of our local guidelines. We don't have them. So this is something which you have to discuss with your fetal medicine specialist and take a call about. There is no proven benefit of aluminum infusion, oxygen, nitrates in management of FGR. All of this have not shown to prove any benefit. There have been very recent trials about the use of sildenafil. Its specific role is in early onset stage 2 or 3 FGR. So basically fetuses less than 26 weeks which already have an absent or a reverse end diastolic flow where they've started sildenafil, and they've said that they could increase the difference between starting therapy and delivery in case versus controls by, I think, a week. That has not necessarily translated into good outcomes afterwards. So again, sildenafil, the benefit is not very clear, but right now they're only discussing the role of sildenafil in very early stage 2 or 3 FGRs. In all of these, goes without saying, maternal conditions like preeclampsia definitely take a priority over anything. When I give these stage-based protocols, I'm assuming that the maternal blood pressure is more or less under control. If you think that the blood pressure is fluctuating, then sure, even if it's a particular stage, we can increase the frequency of monitoring. If you think that the blood pressure is fluctuating, it's staying 180, 100, and there is absent flow, we do not have to wait till 32 weeks. The maternal health takes a priority. So that is always a priority when we take decisions based on a stage-based protocol. So having finished the theoretical bit, I will just discuss 2 or 3 cases where we apply the protocols and see how it goes. So first case is a primary gravida with no risk factors. Her first trimester screening was negative. Anomaly scan was normal. She was referred at 26 weeks with a suspicion that the fundal height did not correspond. So when we see the 26 weeks, what we see? The weight for 26 weeks is at 5th centile. So this is definitely a small baby. Now our next job is to find out whether it is SGA or whether it is FGR. Okay. So weight is at 5th centile, AC is at 8th centile. Okay. Then we go to the Dopplers. All the Dopplers are within normal limits. The umbilical, the MCA, the CPR is normal, the DV is normal. I've not shown the uterines here, but the uterines were normal. So here the weight is less than 10, but more than 3 with all Dopplers normal. So this gets called as a small for dates baby and not an FGR baby. And so how do we manage small for dates babies? According to the stage-based protocol, small for gestational age, you do scans every 2 weeks and you let the pregnancy go till 40 weeks. You just avoid postdatus. So here we do Doppler and scan every 2 weeks. And if the growth stays constant, we can take the delivery till 40 weeks. Sometimes this is not how they behave. The idea of a 2-weekly growth in Doppler is there's a crossover. Sometimes at 36 weeks, 37 weeks, if we see falling centiles or if we see early Doppler changes in the umbilical, then they switch category to FGR and then we manage them as FGR. But this is how we would manage a small fetus based on the Barcelona guidelines. The next case, she's a 35-year-old primary gravida. First trimester screening was not done. Anomaly scan showed high resistance in the uterine artery. By this time, it is too late to start aspirin. Aspirin after 16 weeks has no proven benefit. So here, unfortunately, she develops preeclampsia at 25 weeks. When she develops preeclampsia at 25 weeks, and so we get a growth scan done at 29 weeks. There probably was an earlier scan, but I didn't have record of it. So at 29 weeks, the weight is at 5 centile. Weight is at 5 centile, so I will not directly label it as FGR yet because it is not less than 3 centile. But then I already know that at anomaly scan, the uterines were high resistance. So that's likely to continue now. Plus there is preeclampsia. So there is enough evidence that this is placental insufficiency. So now I already know that this is definitely FGR and not SGA because the uterines were high and the weight is at 5th centile. Moving on, when we did fetal Doppler here, there is ample evidence. There is absent end diastolic flow in the umbilical artery. So absent end diastolic flow is a direct criteria. We directly call it FGR. If it is absent flow, next what I look at is the ductus venosus. Ductus venosus is normal. So absent end diastolic flow makes it stage 2 FGR. Stage 2 FGR, what is the management according to Barcelona protocol? According to Barcelona protocol, we repeat scans every 2 to 3 days. And if possible, we take it till 34 weeks. So that is the protocol. This baby obviously did not go all the way to 34 weeks. Very few absent end diastolic flow with PIH diagnosed at 29 weeks will stay. It became stage 2 and we had to deliver somewhere around 31 weeks. But we still managed to gain 2 weeks, which is not bad, at least as far as outcomes are concerned. The weight gain might not be much. From 700 grams, it must have become 800 grams. But the gain in maturity really helps a lot. And of course, we covered with steroid and maxills at diagnosis. And then case 3, these are the more insidious ones. Completely low risk pregnancy so far. First trimester low risk, uterine was normal, anomaly scan normal, a growth scan at 28 weeks was normal. Again, this is something I have not covered. What should the protocol be? How many growth scans should be done? That's a whole new discussion. We can take it later, but here a growth scan was done at 28 weeks and then a final growth scan was done at 35 weeks, which was the protocol of this place. At 35 weeks, we saw that the growth was at 9 centile. If we see, the fall in AC has been there. It's not 50 centiles, but there's a flattening of the abdominal circumference. So anyways, the weight is less than 9 centile. So then when we see the weight of less than 9 centile, it could either be small for dates or late onset FGR. So what do we do next? We look at the growth charts. The drop in centiles is not severe. So again, it could still be small for dates or FGR. Then we look at the Doppler. If you look at the Doppler, umbilical is 80 centile, so it's normal on the higher side, but still normal. On the other hand, MCA is 2 centile. So there you go. You have a Doppler abnormality, and where the MCA is high diastolic flow, CPR is low. So now the moment you get a Doppler abnormality, we will label this as growth restriction. And what kind of growth restriction? Late onset growth restriction. And what stage? Because the umbilical is still positive end diastolic flow, it stays at stage 1 FGR. Okay. So when we say late onset stage 1 FGR, there has been a cerebroplacental redistribution. Again, what do we do? Low CPR, yes, that means there is mild hypoxia, but at 35 weeks, is there a reason to deliver? And according to my protocol, the answer is no, especially since the mother also does not have preeclampsia yet. So how do we manage stage 1 FGR? We do weekly scans for Doppler AFI and alternate week scans for growth, and then we deliver at term. So this patient had 2 more scans. She had 1 scan with just AFI and Doppler. It continued to stay normal, and so she had a final scan at 37 weeks, and eventually we deliver at 37 weeks. What are my modes of delivery? Here, because it's stage 1, we can still give a trial of labor. It does not have to be a planned section directly, but it'll have to be a case which can be monitored properly during labor. So to summarize, ultrasound and Doppler become the mainstay for management of FGR. Our very first goal is to weed out the slightly small babies who can still potentially be healthy babies. Our second goal then is to differentiate them from FGR. And once we've diagnosed FGR, we stage them and we follow up them, monitor them, and deliver them strictly as per the protocol. Thank you.
My God, Shetal, phenomenal, phenomenal. No other words to describe. Phenomenal with a capital P.
Thank
Right
you.
from definitions, the myths which have been there for ages, you've covered it all and beautifully well. Believe me, I've not moved from this chair. Of course, I had my this thing video off, but you just enraptured us. I've never seen a better coverage of a topic where people, if the students don't understand this, then I'm sorry to say, then there's something wrong with the student. That's how it is. Because it's been so clearly made that these are the concepts today. Let's throw all that behind. Let's get to this protocol based I think we can save a lot of babies, save a lot of prematurities, cover by a couple of weeks, cover by at least 4 to 7 days and do it. I mean, I just don't know. It was one of the most beautifully done lectures on FGRs I've heard. We've heard so very many in most of the seminars and webinars, but really from compliment from my side and from the entire AFG team, I think should be that.
Thank
Just two
you.
questions.
Yes, sir.
One was perhaps we always talk about SGAs and the 10th centile. Now, we've seen certain reports where there's a discrepancy between AC and the expected fetal weight. Expect maybe 7 centile, and the AC is about 15 centile. So we still take the lesser one, don't we?
Yes, we generally take the estimated weight. So that's where the problem with the growth chart comes. So if we use, the problem is, if let's say if you do not have a reporting software, which is fine, what centiles we use are the ones which come up in the ultrasound machine. And what I have noticed is, especially the centiles which you see on the ultrasound machine, they are the Hadlock graphs. They're the oldest graph. They do not perform well after 30 weeks. If you see those charts, you will see there'll be so many head circumferences which will come at 5 centile when the head is not small. There'll be so many ACs. So, by common knowledge, like we know at 36 weeks, if I'm seeing a weight which is 2.1 kilo, we know it's a small baby from experience. We don't need centiles for that, right? But sometimes those graphs will give you where the AC is small, depicting that it's a small baby, but the weight will be 11 centile. So the problem is the charts that are there in the machine. So then what I do is I just try to weed out the high risk. Like if it's I go to different centers. Fortunately, I have the same software in every center, but there are one or two where I don't. So what I then do is I just go by whatever I can pick up to make it, label it as FGR, because we do not want to lose those FGRs. So if it's a machine centile and if my common sense tells me this is a small baby, I'm going to call it small and put that baby up for monitoring. So it's a problem with the charts that are used. But yeah, even with proper charts, if there is discrepancy, I usually tend to stick to estimated weights, because estimated weight also takes into account femur, which is also an equally good marker, or quite a good marker for nutritional deficiency, and not just the AC. So I stick to estimated weights.
And when you do your, let's say we are an average low risk patient who's being monitored for growth scans, what is the best time we should start the growth scan? How often we should do it for all the patients? Disregarding with the high risk category, but
Correct.
routine patients coming for follow up, this gestation first, second, third, and should every be along with the color Doppler?
So again here, there's been a lot of controversy and talks. So up till now, they used to say that there is no proven benefit of any growth scans. Like that's what the data used to say, that it's not improving obstetric outcomes, but that's been old data. Now, when we do growth scans, it's for two reasons. Not just for the weight, but also because we can pick up certain late onset abnormalities, like which can be picked up only if you've done a scan in the late trimester. So there are no standard guidelines, but I would say you do according to the set of patients that you have. If your practice is mainly the kind of patients who are okay with 2 scans, then I would say there should be 2 growth scans, one in a low risk population around 30 weeks and a follow-up one around 35, 36 weeks. If you cover that 2 phases, it'll pick up late onset anomalies, and it will also give us a good comparison in the immediate past as far as the falling centiles is concerned. As far as Doppler is concerned, the only place where I will insist that you always do a Doppler is the very last term growth scan. Because at 36, 37 weeks, like we've seen, if the fall in centiles is still such that, it's falling above the 10 centiles. So if we only use their estimated weight as a cutoff to switch on Doppler, we might not pick up those late onset FGRs where the growth is okay, by definition more than the 10 centile, but the MCA is showing high, like a increased diastolic flow. Even when I see that, here again, there's a controversy. Earlier, they used to say that the growth is normal and just the CPR is low. It might not mean anything, because unfortunately, the MCA does tend to become false positive at term. So the way we practice it practically is, if the patient is completely low risk, like you do a growth scan at 36, 37 weeks, the weight is okay, the patient is completely low risk, the Likert is okay, there's not been a drop in centiles, and the only thing I'm seeing is a low MCA PI, I will wait. I will call her after a week. If this low MCA PI or this low CPR is persisting after a week, By then, she must have become 38 weeks. I just advise that better to induce because we don't know. There have been papers now which have said that this has kind of worked. An induction between 38, 39 weeks for a low MCA in otherwise okay cases does not have, like it has shown to improve some outcomes. Like they have said that MCA should not be ignored. So to keep it very simple, if your population is such that they can afford two scans, two growth scans, one around 28, 30 weeks, the other around 36 weeks, and at least the last scan always and always with Doppler. If your population is such that two growth scans can become a problem, then one scan at around 30, 34 weeks, which will be a good compromise for looking at anatomy also and for picking up those late onset, because 34 weeks is late enough to hopefully be able to pick up any late onset changes. And then after that, and that 34 weeks one then has to be with the Doppler. And then if the patient has not crossed 40 weeks, then we can just leave them at that. I mean, like that in a low risk patient.
This quartiles you talk about, two falling quartiles should be in a maximum what span of time?
They
Which
have
two
said,
scans do you
they have
scan
said, they have said you can take the anomaly scan because that's when we first start looking at centiles. So
at 30 and
anomalies, yes, 22 whenever your current scan is.
Okay, got it. Thank you so much.
Sir,
Yes,
too good a talk, no doubt about
Thank you,
it.
sir.
Now I have some queries.
Yes, sir.
We have been taking all the other parameters except for the placental size and weight. Why don't we start considering placental size and weight for diagnosing small for gestational age and FGR?
Sir, there have been studies where they have tried to do
It goes from placenta to the baby, no?
Correct. But the thing is, especially as the gestation advances, there have been studies where they've tried to do 3D volumetry of the placenta to look at the volume. But technically, the reproducibility of that is very, very low. And we've seen that placenta in itself can have a lot of varying morphology. Like placentas which tend to be just in the fundal region might appear thick because, you know, they're just covering the fundus, so they're short but thick, but they're healthy. Versus certain placentas which are entirely along the anterior wall, where that they might not be that thick, but the area is good. So they realize that it is there's a lot of variability. The same examiner measuring the placenta volume on the same baby, you know, blinded studies, they could realize that it's not reproducible. And second, they say first trimester high uterine PI and a low PAPA or a low PLGF are much, much better markers of this placental smallness than the placental morphology. The one thing I have not talked about deliberately is placental calcifications. These days, they do not include that as far as placental function is concerned because we've got these biomarkers and all. But the way I use it is if I see placental calcifications, I know in my head it's highly unlikely this is going to be a SGA baby. This is most likely going to be FGR baby. Yeah. But right now, like when we had all these things, these placental weight, and weight is difficult, but placental volume and appearance, we didn't have first trimester, we didn't have PAPA, we didn't have PLGF. So if in the presence of even a uterine artery PI so when I was at Mediscan, when we first started doing it, we were not doing uterine PI at NT scan. In fact, I think we just included it as part of the protocol while I was training. So now with the addition of this PI in the first trimester and addition of PAPA, it beats hands down all the other surrogate markers. But of course, if you see a non-homogeneous looking you will see it, especially early onset FGRs, like you said, sir, we will see it. We'll see a small, thick placenta, non-homogeneous, dirty looking, lot of fibrin, and it's there. So it just corroborates what, as far as me managing is concerned, these parameters are more objective, more on and off, more non-ambiguous. So we kind of stick to using them as far as follow-up and management is concerned. But you're right.
Second question is, can you give us the exact weight of the fetus at different times of gestation?
So
you do consider weight, correct?
Correct. So that's the other fallacy of growth restriction, that what weight we measure is finally we measure head circumference, abdominal circumference, femur, correct, and there's an algorithm which gives us the weight. So the variability of that weight in the best of hands is 10% plus or minus. And when I say best of hands is when you know you've taken all those sections in the proper fashion. There are a lot of factors which affect it. Like if there is oligohydramnios, you tend to undermeasure. Then there are studies that has shown even in experienced people's hands at extremes of weight, At FGR and at LGA, that inaccuracy increases quite substantially. It's also because, let's say in LGA, when we have a big AC, it's because of a lot of subcutaneous fat. Whereas when they measure, when they use the formula, they take the AC, they don't think the AC is because of the fat. So the density of the fat is not the same as density of the muscle or the intrauterine organs. So you tend to underestimate our LGA baby because it's big because of the fat and not protein in that sense. So at extreme, and even for FGR, at the extremes of both weights, the accuracy of your measurement goes down. So which is why they've tried, again, there's like a lot of work going on that they've realized ultrasound definitely fails. Like estimating weight definitely fails as a marker for FGR because A, there's inaccuracies in estimation. B, we are not picking up those appropriate for gestation FGRs, which are more than 10 cetal, but definitely small. They're trying to find certain other biomarkers if they come up with whose presence might tell you more. But right now, that's all we have.
Why they? Why can't Sheetal?
So Shetal is not equipped for that. All those biomarkers and all is definitely. And Shetal has done a lot of estimated weight. Gochis also, Karthik sir will speak for that. But it's just the way it is.
Okay. Other question is, how soon can we do NSC? You were talking about 24 weeks NSC because when we study and we teach, we talk about NSC should not be done before 26 weeks.
Agreed. So we do NSTs only if we are planning to salvage the baby, not 24 weeks. But let's say at 26 weeks, there is stage 3 and your patient is capable and NICU facilities are there and we are planning to monitor. Then we do NSTs at 26 weeks. The idea will not be to look for decelerations. Idea will be to look at some beat to beat variability and absence of spontaneous idea there'll not be accelerations, but absence of any spontaneous decelerations and a flattening of the NST is the two things we would look at. All whatever the studies that they have done, the truffle trial and all had used computerized CCT, where they use the STV, which was calculated by the machine. They have various cutoffs. We don't have them here yet, but I've been hearing at our a couple of conferences that I heard that getting a CCTG is not that big of a deal. It's just a software update that needs to be done. But so far we don't have it. So we make use of what we have. We look at beat to beat variability and absence of decelerations if your intent is to save the baby, which means when the baby is viable. So after 26 weeks only.
Okay. Other thing is, what is the role of arginine sachet as far as oligohydramnios is concerned?
So oligo is a different case. So there has been some role of improving maternal hydration, which has shown to improve oligo. So arginine sachet essentially does that. It increases the intravascular volume and kind of improves maternal hydration. I have not found studies definitely comparing arginine sachets, but there is enough evidence that improving maternal hydration in general and in clinical practice, I have seen it being used where the moment you give oligo, we have started the patient on arginine and it has worked. But those are all observational trials. I don't have a case control. And I would myself say not keep a control group where I would say don't give. But I would insist on the mother to at least arginine plus at least 2.5, 3 liters of water every day. That is something that, but definitely no role of IV alamine and oxygen and all that, no role. No role.
Sure. Thank you. Thanks
another thing which may work is basically you need to improve the uterine artery or the placental blood flow. So one of the things which is advocated is ask the mother to walk in water, waist deep water, and this may help. I mean, again, anecdotal, we don't have a clear evidence, but this is something which is possible, and I think we've seen results. Okay, to take Manohar's question a little forward, if you wish to deliver the baby at 38 weeks, would you give steroids?
No. The only country which gives steroids only country guidelines which gives steroids after 34 weeks is RCOG. Almost all guidelines stop short of giving or recommending steroids at 34 weeks. And this is when, in cases where the babies were not growth restricted, this is what like general guidelines for delivery of whatever. In growth restricted babies, because of the stress and because of that cortisol response, which will be there in the baby already, there is actually a question of, do we even need to give at even 34 weeks? Like, do we wait and give because the baby will have enough of stress response to have those steroids in it on its own. But yeah, 34 weeks ke baad, usually I don't advocate steroids for FGR. The only case after 36 weeks, I would advocate steroids if she's like a type 2 DM, where we know that the lung maturity is affected, then admit, give steroids, get her sugars under control. Uncontrolled GDMs where you're not comfortable waiting even till 38 weeks, because those are the ones which are a bigger problem. Other than that, in FGR after 34 weeks, I wouldn't. And Maxelf 30 to 32 weeks.
All right, to turn the question backwards, once you've diagnosed FGR at say around 32 weeks, would you give a steroid in anticipation that you may have to deliver this baby a little earlier because you don't know how it is going to progress? So would you advocate giving antenatal steroid as a routine on diagnosis of FGR?
So as far as improving outcomes after steroid is concerned, the maximum advantage is if you are anticipating delivery within the 1 week after giving the steroids, which is why if at 32 weeks, I'm seeing only an increased resistance, but not absent flow, I would hold on, because especially when such a baby is going to be under close monitoring, let's say from increased resistance, she becomes absent. Even at that stage, we will have those 24 hours to cover with 2 shots of steroids and give max, because the maximum use of advantage of steroids is within 1 week of giving. And now because of we know that giving those weekly and those top-up is now obsolete. Like, it causes more harm, it causes leuko and encephalomalacia and all that. So that we don't repeat a steroid shot within at least a month. There's no top-up or anything. So I usually don't write steroids when I see increased resistance at 32. I will definitely write it if I see an absent flow. And there is time to give steroids at an absent flow also.
All right. So thank you.
In the same context, yeah. What has been seen is that growth restricted babies before 34 weeks, if steroids are given, then it eliminates that problems of prematurity and probably helps the baby do better as such. What is important is hypoxia, acidosis, and prematurity. These are all insults, of which I think if we can prevent prematurity, that means delivering the baby before 34 weeks, or with without the help of steroids, then that is something which will eliminate some kind of a problem to the baby. Acidosis, yes, definitely it's important, and as you rightly said, that ductus venosus is the one which is going to determine, and that will be considered only around 20 to 30 weeks as such.
Yes,
I'm really happy that you mentioned about alanine and other things as such, which is not helpful. And that is why we've seen a number of times where patients are admitted, given intravenous drips. Maybe it helps in increasing the amniotic fluid volume, but not more than that, I think. As such.
Yes.
The only 3 things which have been shown to improve results is that if a mother is used to smoking, you stop that smoking, it makes a difference.
Yes.
If the mother is undernourished, you give supplementation in the form of micronutrients, it helps as such. And the third thing is, if the mother has malaria or if she is in endemic malarial place and the malarial treatment is given, probably that improves the fetal growth. Besides that, nothing.
Definitely. Agreed. Thank you, sir.
Thank you. Thank you.
The only one other case, sir, where you asked about giving steroids at 32 weeks is if she's severe preeclamptic with her blood pressure all over the place. Then definitely. But that will be because of the preeclampsia, not really because of the...
in that case, again, that stress is there, na?
Yes. Yes.
Again, the role of steroid is controversial.
But they stay till now, still give. Before 34 weeks, they do.
I'd just like to add a point over here that, once upon a time, when we were students, we used to say that, the stress improves the outcomes, so the pulmonary maturity is more. But they've shown studies where they've shown that FGR, the risk of all problems increases despite the stress. So you need to give the RDS would definitely increase. So you definitely need to give the steroid.
Yes. Thank you, ma'am. Yes.
Thank you.
Shetal, it'll be redundant to say that it was an extremely good lecture, very clear line of thought and very crisp messages. And you're a good teacher because you not only give clear answers, clear concepts, but you also follow it up with examples and put it in perspective. Thank you very much for being with us.
Thank you so much, sir. Thank you. Thank you.
Okay, so we go to the last part of the program. And, we always said that the proof of the pudding is in eating it. So the proof of what we do, the decision to deliver, is basically justified by the neonatal outcome, the short-term and the long-term problems. So we cannot complete the discussion on fetal growth restriction without looking at what happens to these babies when we deliver. These babies carry the risk of not just being small, but being premature by delivering them early. So what happens to these babies in the short term and the long term is what is going to decide whether to deliver these babies was proper or not. To do justice to this problem, we have Dr. Jayashree Monkar. She's the professor of neonatology. She's a retired dean and head of department of neonatology at Sion Hospital. And she was in charge of the human milk bank at Sion. Currently, she is the trustee of SNEHA, that is the Society for Nutritional Education of Health and Action for Women and Children. She's been a chair of NNF Accreditation Committee. She's been a part of the technical support report expert committee of MCH at the Biotechnical Department of Biotechnology, and she's been a member of the advisory group on human milk banking. Apart from all this, she's received the Lifetime Achievement Award from the Breastfeeding Promotion Network India, Mumbai. Apart from all this, she's extremely good at her work, very vocal, and very, very simple and silent. So she will not put in words where they are not needed. Madam, the window is yours. Thank you very much for being with us.
And I must say that it's been a wonderful morning. I really enjoyed it. And there was Sheetal, your presentation was a real treat. The finer nuances that, we sometimes, when we're looking at it from the other side, that why did the obstetricians do this? Why didn't they do that? Because we have DM students. So all these discussions are sort of kind of valid. So I think it was really wonderful. I mean, from whatever, 9:30 till 12:15, it's been very well spent as far as I'm concerned. So thank you, Dr. Karthik, for having invited me to be part of this. And so what I shall be talking about is the neonatal outcomes in FGR, their early problems and the late sequelae. So basically, obstetrics and neonatology are really two sides of the same coin, because we have one common objective, is that the pregnancy should culminate in a happy mother and a healthy baby, and both should go home safe and sound with, the usual stay of maybe 3 to 5 days. But unfortunately, this is not always possible. And especially when the intrauterine environment becomes hostile for the fetus, and the fetus lands up with a lot of problems. When they are born, they sort of spill over into the neonatal period. So one of these problems is fetal growth restriction, as we've been discussing since morning. And as we've already said, that to put it very simplistically, it's failures of the fetus to achieve its genetic growth potential in utero. Now, postnatally, after the baby is born, we will again, describe this baby as having been fetal growth restricted, when, as you all have already said, the weight of the baby after birth is less than the third centile. Or as per the consensus-based definition of the growth restriction of newborns, it would be if the baby satisfies any of these following five criteria. So that would be the anthropometric parameters, any of them less than the third centile. In addition, perinatal risk factors associated with FGR, or a clear-cut antenatal diagnosis of FGR, then it just gets moved forward to FGR. As you all have already been, stating time and again since morning, that all SGAs are not FGR, and there can be some FGRs who need not necessarily be SGAs. So I will not go again into more description about that. As has again been very beautifully brought out in one of the presentations, all the causes of FGR basically divided into maternal, fetal, and placental. Large focus on the placenta, but as from our side, when it's not the maternal causes, of course, very common, but from the fetal aspect, it is chromosomal anomalies, congenital anomalies, intrauterine infections, and fetal anemia, which are the common causes for non-placental and non-maternal causes of FGR. Irrespective of what the the etiology, underlying etiology, we heard the whole of the maternal causes and one of the presentations. And of course, the placental issues have been discussed at length. So especially for these two, not so much for the FGRs, where there again it's fetal tissue the cell hypoplastic or not developing adequately. The basic common final common pathway is fetal hypoxia and poor nutrient supply. So this, of course, to save the fetus, results in redistribution of the cardiac output to protect the vital organs, including the brain, the heart, and the adrenals. And what also happens is some reprogramming of all the fetal organ systems, and that results in long-lasting structural as well as functional alterations. And these spill over into childhood, these spill over into adulthood, and with all the long-term complications, particularly the cardiometabolic complications, which we will address a little later. So now when there is a birth of an FGR fetus, it's like, and especially when it's a preterm FGR fetus, and most of them these days are the preterms and preterm FGRs that we handle. There's been a paradigm shift in our in the kind of babies we get these days. When I was, say, 20 years ago, it used to be all about perinatal asphyxia, and it used to be the late FGRs, which were very common. Today, it's all about prematurity, and with your intervention so clearly chalked out, it's the preterm and the preterm FGRs which really fill most of our NICU. So basically, like I said, when you have an FGR, then it opens up a Pandora's box, because each and every organ system in the body can be affected by FGR and leading to a whole host of neonatal complications. So let's take a look at some of the problems that we have to deal with when you deliver these FGR babies. So starting right with the early neonatal problems, one of the common problems could be perinatal asphyxia. This part of perinatal asphyxia, perinatal depression also. So perinatal, basically, you're delivering many of these babies preterm. So there's a higher LSCS rates and all the problems that are related to an preterm LSCS delivery. Because they have growth restricted in utero, because of the chronic in utero hypoxia, the labor is not well tolerated in these babies. And just the stress of a labor could actually tip them over into perinatal asphyxia. And if an FGR baby, be it an early FGR or a late FGR, gets tipped into perinatal asphyxia, then this baby is going to need resuscitation. This baby can develop multi-organ dysfunction, including hypoxic ischemic encephalopathy. And the main thing is, in preterm babies, if they have got evidence of perinatal asphyxia, especially with HI, then the outcomes are really, short-term outcomes itself are bad. The mortality is extremely high in these babies. And for the late, FGRs, again, perinatal asphyxia, HI, the whole complications of later adverse neurodevelopmental outcomes becomes a major issue in these babies. So starting right from the labor room, perinatal asphyxia. Then another common problem that these babies develop is hypothermia, basically because they have insufficient layer of subcutaneous fat. They have an increased surface area to body weight ratio, so they tend to lose heat from greater surface area, so easier heat loss, and decrease in the metabolically active pool of brown fat. This is the one which undergoes breakdown into free fatty acids, and as a byproduct, heat is formed. So this is one of the baby's heat producing mechanism whenever there is cold stress. But this is affected in small for gestational age babies, in FGR babies, because they do not have adequate amount of brown fat. And this problem starts right from the labor room. And studies have shown that if by the time the baby, that preterm is shifted from the labor room to the NICU, if the baby is hypothermic, then the neonatal mortality in the first 28 days significantly increases. And therefore, our focus would be starting right from the labor room to see that we try to block all these 4 avenues of heat loss: conduction, convection, evaporation, and radiation, of which evaporation and radiation are very important avenues of heat loss in the labor room. So one of the things, so besides our usual, preparation for delivery in the labor room, including switching on the warmer in advance, pre-warming the sheets, when babies are less than 32 weeks of gestation, then they would be, as soon as they're born, they're wrapped in this polythene sheet. The head is covered with a cap so that we can minimize the heat loss. So we create a micro environment for the baby. Don't even dry the baby. You just wrap the baby in a plastic sheet, then continue your resuscitative measures if it is required, or whatever respiratory support, early CPAP in the labor room that is required. But by keeping the baby covered in a plastic sheet. And this baby would be transported to the NICU in this plastic sheet, and only after the baby's temperature stabilizes that the plastic sheet would be in the NICU under the radiant warmer or in the incubator, that's when the plastic sheet would be removed. Then, of course, babies warm transport to the NICU. Once they're transported to the NICU, if it's an extremely preterm baby, there would be an incubator care. Otherwise, by and large, we largely, manage them under the radiant warmer. And again, the whole focus would be on temperature maintenance, which would be one of the most important, steps in management at all stages. Another common problem that these babies can have is hypoglycemia. Again, it's a suboptimal glycogen stores, a decreased fat mass, impaired ability for gluconeogenesis, and an increased insulin sensitivity. And sometimes in these FGR babies, studies have shown that the chronic hypoxia actually leads to placental, leads to hyperplasia of the type 2 cells of, of the beta cells of the pancreas, and they have hyperinsulinemia. So the typical hyperinsulinemic baby, whether it's PHHI, these are large, chubby fellows like the IDMs, But these SGA and these SGA baby just behave like those persistent hyperinsulinic babies, and they may require intravenous fluids and management of their dextrose. You start to feed them, the sugars drop again. So it becomes really a challenge for managing these babies. And the point of note is that hypoglycemia, especially when it's a symptomatic hypoglycemia, and symptomatic means it could be lethargy, it could be neonatal seizures, then it is again an additional brain damaging mechanism. So again, throughout their stay with us, the preterm FGRs again will get at least twice. I mean, initially they would have 4-hourly sugar monitoring, more frequently if their sugars are on the lower side. But when even the late FGRs, at least for the first 72 hours, we need to monitor their sugars. And typically, when not all late FGRs will get admitted to the unit, especially the ones whose weights are above the 10th percentile. But these are the ones where suddenly, they'll get transferred from the postnatal care ward for hypoglycemia on day 3, day 4. So these again are some things that, on the PNC rounds, residents are cautioned that you need to check the sugars intermittently to see that the sugars are in the normal range. So we want to prevent hypoglycemia-induced brain injury. As you all know, that respiratory problems are common in preterm babies, and actually these problems get aggravated in FGR babies. When we were residents, like I said, we were always taught that because they are FGR, the stress in utero, the cortisol production actually improves their respiratory outcomes, but studies, there is enough evidence to say that this is not true. Preterm FGRs at an increased risk for respiratory problems, in fact. And respiratory distress syndrome, can generally manifest starting right from the labor room. And they need, some may need non-invasive respiratory support. Most of them we try to manage with non-invasive respiratory support at a CPAP and sometimes non-invasive ventilation using a nasal mask. Some of them might even require invasive ventilation. Now, the whole point is that when you start the respiratory support early in the labor room, as soon as you see signs of retractions, especially in the extremely low gestation, some signs of retraction, we start CPAP early, stabilize the baby in the labor room, and then shift the baby on either a TPS resuscitator or a transport incubator, a transport ventilator if you have. But this early CPAP reduces the need for invasive ventilation. It reduces the need for surfactant also. So after, for the last 5 to 7 years now that we've started labor room CPAP, our need for surfactant also has significantly decreased. Now, one more problem in late FGR babies is when they pass meconium in utero, they can inhale it into their lungs. And meconium aspiration syndrome, again, in the late FGRs is a common problem. And with all its problems related to is increased risk of air leaks and increased risk of persistent pulmonary hypertension of the newborn, which is another, tricky kind of a situation to manage, and these babies may require prolonged ventilation. Then again, coming to the GI issues, by virtue of the fact that, there's redistribution of blood in utero when there are FGRs, we want to protect the brain, heart, and the adrenals, then the gut tends to get a little hyperperfused, and this can cause dysbiosis and stasis in these babies. So preterm FGR babies are more likely to develop feed intolerance in the first few days. And another very, dreaded complication for neonatologists, that is necrotizing enterocolitis. This necrotizing enterocolitis generally, manifests about by the second or the third week of life when the baby is on full feeds. But these FGR babies are definitely, at increased risk for increase FGR, the extremely preterm babies are at increased risk for necrotizing enterocolitis, especially when there is absent or reversed end diastolic flows. And it is much more common in babies who are formula fed. And breast milk has been found to significantly reduce the incidence of fetal growth necrotizing enterocolitis. And it's really a horrible thing because it's basically the intestine is ischemic, then the bacteria translocate, and then the intestines, you can have perforations, you can have gangrene, they can land up into, requiring surgical intervention. And therefore, the morbidity and the mortality in both these, NEC babies is really quite dreaded. So it's something that we really dread. So we said that, yes, one factor which helps reduce. So we don't see NEC very commonly, even in our extremely low gestational age babies, because we're very aggressive in our enteral feeding, this thing, and using human milk, and when that's not available, pasteurized donor human milk, we don't really see NEC that, touch wood, we don't see NEC that commonly. I mean, in a year, we might have 2 or 3 or maybe at the most 4 babies who really manifest with advanced stage 3, 2 to 3 NECs, right? So basically, what is important is that mother's milk is very, what should I say, conducive, and it's not only for reducing the risk of NEC, but it's likely, actually, it's a panacea for all ills. So when you use mother's own milk today, there is enough evidence to say that mother's milk reduces the risk of feed intolerance. It reduces the risk of late onset sepsis. It reduces the risk of necrotizing enterocolitis, retinopathy of prematurity, bronchopulmonary dysplasia. It reduces the NICU stay and is, of course, cost saving. And what is very important when you use mother's own milk or till mother's own milk is available, pasteurized donor human milk, there is also improved neurodevelopmental outcomes. And there's now hardcore evidence to prove this. So having talked about mother's own milk, like I said, if that's not available, the next best alternative is to use a banked human milk. And Sion Hospital has the credit of having the first human milk bank in Asia. And this is how it stood when it was initially set up. We use this shaker water bath as a pasteurizer, an indigenous modification, which served us well for the first 25 years. But you have to keep up with the times. And now this is our current state-of-the-art human milk bank. We are now also a zonal reference center for human milk banking recognized by the government of India. And now we have all automated pasteurizers and state-of-the-art equipment. Now, coming back to the other morbidities that these babies can have, preterm FGRs are at increased risk for polycythemia because of the in utero hypoxia, so more erythropoietin response, polycythemia. When they come out and, when they're born, the ambient oxygen or whatever additional, support they require, they also have a problem of neonatal jaundice. But because of the polycythemia, the neonatal jaundice could also get aggravated, so they may require aggressive phototherapy. And, of course, very rarely these days an exchange transfusion to prevent bilirubin-induced neurological damage. Other problems are intraventricular hemorrhage, which again, with all the aggressive management, especially when they require, say, boluses and, invasive ventilation, all that would predispose them because the germinal matrix is so, fragile and very easy to rupture, especially when the babies develop what is called a pressure passive circulation. IVH can occur in these babies, and periventricular leukomalacia, that is because of the ischemic brain damage, these babies are at increased risk for and require monitoring. Of course, our big bogey always is neonatal sepsis. It can be early neonatal sepsis, which can be very, which I say, it's a very aggressive kind of a disorder and really requires intensive management. And again, the big fear is late onset sepsis because when they acquire it from the hospital environment, it could be multi-drug resistant. And neonatal sepsis definitely increases the risk of poor neurodevelopmental outcomes besides other short-term morbidities, as we'll come to later. And therefore, it's all about trying to prevent. It's hand washing, and hand hygiene are, of course, the first and the most important step. Then, of course, we have our infection control bundle. So you have a ventilator-associated pneumonia, that's a VAP prevention bundle, a CLABSI prevention bundle, or feeding bundles to try to reduce the risk of postnatal sepsis. Because postnatal sepsis really complicates everything. It aggravates the lung disease, it aggravates the eye problems, and again increases the. And of course, antimicrobial stewardship is very important. The right antibiotic at the right time, in the right dose, for the right duration. Try to de-escalate wherever possible. These are some of the things that we need to that we try to follow to be able to reduce the risk of hospital-acquired infections. Then besides, of course, breastfeeding, another very important strategy, which one needs to use all the time, is kangaroo mother care, because kangaroo mother care has shown to have a plethora of benefits, right from cardiorespiratory stability to preventing late onset sepsis, to better weight gain, reducing hospital stay, and very importantly, better neurodevelopmental outcome. The success of breastfeeding also at the time of hospital discharge will be more when one uses a kangaroo mother care. And again, there's evidence to say that when you start immediate KMC in the labor room for the the stabler, the larger FGR babies who do not have respiratory instability, and when you continue KMC throughout the neonatal mortality, there's a 25% relative risk reduction in the neonatal mortality at 28 days of life. Another very important strategy that we have to, as neonatologists, follow is focus on ensuring physiological stability for these babies, trying to decrease their stress, trying to protect their sleep, and to promote behavioral organization so that this results in better short-term outcomes also and better neurodevelopmental outcomes. And these strategies are what are together called as developmentally supportive care. So developmentally supportive care includes allowing family-centered care. And so I must say that Sion Hospital has been what should I say, we've been pioneers in this field, right from the time of Dr. Fernandez. I remember even when I was a student working under, we always allowed free entry of mothers into the unit. At that time, when we didn't have so much equipment, there used to be human apnea monitors for their babies. So they would stimulate their babies. But of course, now things have changed. But still, entry of the mother into the unit, participation in the care of her baby, when she talks to her baby, when she fondles her baby, she helps the nurses by changing the diapers. All this is actually developmentally supportive care. Then again, what we need to do is we need to protect sleep of these babies. So everyone should not be on their own trip. Doctors come and do something. The nurses come again. Someone comes and feeds. The other one comes and gives the IV injection. Rather, what is important to protect the sleep of these babies is what is called clustering of care. And you do it according to in large units like us, doing it according to the infant queues may be a little difficult. But yes, our nurses do their care clustering is, their care is always clustered generally around the period of the time of feeding, which is 3 hourly. Then again, we need to provide, sort of a protective kind of an environment, try to mimic the womb by giving them boundaries, so that otherwise their limbs tend to flail. They start moving their limbs when you don't give them adequate boundaries. And these boundaries are provided by a soft nest, which sort of keeps the baby in a flexed position with the with the hands towards the midline and towards the mouth, the legs flexed at the hips and the knees. So it prevents tonal changes in these babies. So this again, nesting can be done, swaddling can be done, facilitated, and of course, kangaroo care, as I said, is a developmentally supportive care. Besides this, of course, prompt redressal of pain. I mean, preterm babies are the ones who get the maximum pain, stimuli. Multiple pricks, so therefore they reduce it by giving long lines, then tubes passed into your throat, into your gut, all kinds of sort of interventions get done. So addressing pain is, and then necrotizing enterocolitis, certain of these things can be really extremely painful, and therefore prompt redressal of pain is very important. And also minimizing noise and dimming the lights when it's not necessary is a very important part of developmentally supportive care. So this is how we would manage, in the early stages, managing the acute problems. And then beyond the first 2 weeks of life, the monitoring has to continue. And what is very important there is growth monitoring. So once the baby has reached full feeds, then we want, and we achieve this, try to achieve full feeds earlier. I mean, even in our unit, because very aggressive, we use parenteral nutrition, but we're also very aggressive with enteral nutrition. We start with minimal enteral nutrition and we scale up daily based on the tolerance of the baby. So you're between 750 to 1,000, but generally by day 7, day 8, they're on full feeds unless they develop feed intolerance. And the tinier babies generally by day 10 to day 12. And why do we want these aggressive feeding policies? Because they can very easily get extrauterine growth restriction. And basically what happens is they get cumulative deficits. If you're not fed them appropriately from the beginning, then they get cumulative deficits of calories and proteins, which the catch-up growth generally then occurs later by 2 years, 3 years of age. So we want to try and avoid or minimize this EUGR. Of course, studies have shown that even if you give the best parenteral nutrition and enteral nutrition, you still cannot get the intrauterine growth curves, help get them to achieve. But basically, EUGR by definition is when any of the parameters, anthropometric, weight, length, or head circumference are less than the 10th centile at 36 weeks of postmenstrual age, or when they have dropped 2 centiles, 2 standard deviations below their birth centile, then that would be EUGR but this is at the time of discharge or at the time of at 36 weeks, whichever is earlier. So basically, we don't want to wait for that, and therefore we need to monitor the growth of these babies throughout their stay in the unit and take corrective measures wherever it is possible in terms of improving their nutrition. Because again, when babies have EUGR, then it increases the risk of late onset sepsis. They don't have the energy to breathe off the ventilator, so it prolongs the ventilation. It increases the risk of chronic lung disease, of retinopathy of prematurity, of metabolic bone disease, and also long-term adverse neurodevelopmental outcomes. It's a significant risk factor for that. So these babies will have psychomotor as well as neuromotor problems, and their final weights and height also could be lesser. Then beyond the first 2 weeks, so we also monitor for the respiratory status, the need for respiratory support. And if a baby has, at end of 2 weeks, is still on ventilatory support, and it's a red flag sign that this baby is probably going to evolve into a BPD. So we need to address these issues, look for infection, look for any other factor which is causing it, treat it, and then consider giving postnatal steroids to reduce the ventilator cost, so that we try to reduce the risk of chronic lung disease or bronchopulmonary dysplasia, as it's called. Then, of course, like I said, monitoring feed tolerance, vigilance for sepsis. IVS screening we do on day 3, day 7, day 14. So that because sometimes, and if we do detect significant IVH, then it needs to be monitored more frequently because of the risk of obstructive hydrocephalus that these babies can have. Then again, like I said, ischemic brain damage, so periventricular leukomalacia screening also occurs at the same time when we do the IVA screening. And then we do one again at 36 weeks or at discharge to see whether there are anything, because the neurological manifestations, that the lower limb, that is, they can have diplegias when there is periventricular leukomalacia. Of course, they can have a lot of cognitive problems also. So therefore, they definitely require screening. Then, of course, after 2 to 3 weeks, we start weekly screening for retinopathy of prematurity, which is done at the bedside. Because retinopathies of prematurity, we'll come to that a little later. Then we also screen for metabolic bone disease and anemia of prematurity. So very briefly touching on bronchopulmonary dysplasia, when the baby requires respiratory support at 36 weeks, then it is defined as CLD or bronchopulmonary dysplasia. And I said the longer the invasive ventilation, the more is the risk, because there could be ventilator-induced lung injury. Now, point to remember here is that fetal growth restriction is an independent risk factor for bronchopulmonary dysplasia. And studies have shown that when SG or FG are infants between 24 to 27 weeks, they are twice as likely to develop CLD when they have required invasive ventilation compared to the AGA's infants of the same gestational age. So FGR again becomes an independent risk factor. Similarly, for retinopathy of prematurity, it's a preventable cause of blindness and also a medico-legal, nightmare. So it requires regular monitoring. FGR infants are at a higher risk of developing at ROP, and they're at a higher risk of having sight-threatening ROP, which requires interventions. And again, poor postnatal weight gain, sepsis, anemia, all increase the risk of retinopathy of prematurity. So we have this tightrope walk. We have to manage everything. We want to promote growth. We have to prevent sepsis. We have to monitor for anemia of prematurity and manage it appropriately. But basically, what is important is the screening. So starting at definitely at 3 weeks, sometimes the extremely low gestational, even at 2 weeks, we will start the monitoring. And as per the national guidelines, any baby less than 34 weeks, weight less than 2 kilos, requires screening. It is done by indirect ophthalmoscopy at the bedside. We give topical analgesia and, of course, pupil dilating drops before the ophthalmologist visits. And they will, till the retina becomes mature, They will do it every 7 to 15 days. And if they pick up any red flag signs, they will do it more frequently. And interventions would be either, laser therapy or VEGF, anti-VEGF therapy, depending upon the severity and the zone which is involved. Then coming lastly to the long-term sequelae, our biggest concern is, during the one is chronic lung disease, and that increases their hospital stays and stuff like that. But if we're looking at long-term outcomes, biggest fear is neurodevelopmental outcomes. Yes, these babies can also have, chronic respiratory disorders, especially when they've had BPD. So they'll have repeated admissions. But our biggest concern, when we're looking at all the studies, we'll talk about adverse neurodevelopmental outcomes. And FGR babies, as an independent risk factor, are at increased risk, whether the early or the late FGRs, they're at increased risk for cerebral palsy, low cognition scores, behavioral problems. But again, like I said, it's multifactorial. FGR, UGR, sepsis, when they have ROP, BPD, when they have IVH, PVL, hypoglycemia, hyperbilirubinemia, all these increase the risk of neurodevelopmental outcomes. But studies have shown that when you optimize the postnatal nutrition of these babies and they catch up their growth by 2 years of age, then the neurocognitive outcomes in these babies are better. So therefore, like I said, it's not only during the hospital stay, but also after discharge, we are always monitoring the growth of these babies. Then coming to the other cardiometric, long-term complication which spills over into adulthood is the cardiometabolic complications. The fetal reprogramming, the vascular remodeling that occurs in utero predisposes this baby to cardiometabolic problems. Now, paradoxically, we said that the neurodevelopmental outcomes are better when they show good catch-up growth. But paradoxically, when they show good catch-up growth in the first 2 years of life, it actually increases the risk of cardiometabolic syndrome. But basically, the bottom line here is that when they are catching up growth, you wanted more of lean muscle, you don't want it of fat. So when the catch-up growth is because of the fat, then the cardiometabolic risks increase. So therefore, these babies are at increased, as adults, they're at increased risk for hypertension, cardiovascular disease, dyslipidemia and fatty liver, obesity and type 2 diabetes, premature puberty, polycystic ovarian syndromes, and a propensity towards cancer and a lot of neuropsychiatric problems, and therefore an increased, a lower lifespan. So I'd like to end by saying that fetal growth restriction leads to severe several neonatal problems. It prolongs the hospital stay. As it is, the preterm babies will stay for 2 to 3 months, the extremely low gestational age and extremely low birth weight babies. And FGR complicates it, and so they can stay. Sometimes we'll have an odd baby staying even for 6 months. The problems that these FGRs have are carried on into childhood and adulthood. And therefore, a life cycle approach, access to good antenatal care, good NICU management, and further research is needed to be able to reduce FGR and therefore improve neonatal outcomes further. Thank you so much for the patient listening.
Boy, I'm glad you could attend this session, madam. We thought, as obstetricians, my job ends when I deliver the baby and hand it over to you.
I know, I agree.
When the baby cries, we feel that our job is done. But what goes beyond is really something which was eye-opening, and I'm glad you put it in such a perspective. So at this juncture, after having met you, Prashant, and being in contact with the pediatricians and the breastfeeding movement, we feel that now the definition of pregnancy should change. It is not just 9 months. It is 15 months. So the job of an obstetrician ends not just after the delivery of the baby, but once the baby starts feeding. And our job doesn't just end with the delivery. It requires a lot of attention to details and infrastructure at the time of delivery and transport of the baby. So, without a good pediatric support or a neonatal support, we are helpless. So, in order to do that, let me come back to the whole thing that, in order to do all this, you need to have a baby-friendly hospital initiative and a setup, a baby-friendly setup, and Manyata certification helps you with all this. So I would urge all the youngsters and colleagues to think about the maternity care as not just delivery, but delivering proper care so that the baby and the mother do well. Madam, yes, madam.
Just that, I mean, I think as obstetricians, residents must remember that they need to do, even during the antenatal period, sort of introduce the concept of breastfeeding to the mothers and, do a breast examination, because that goes a long way in the early feeding. Because
Yes.
obstetrics play a very important role.
Yes, and when the baby is separated from mother, don't give up expressing the breast milk and giving it to the baby, because that is the amrit that the baby receives. So with these last two talks, what we found out was that what is important is growth charts to monitoring growth, either intrauterine or extrauterine, and you need to be very, very vigilant. Thank you very much, madam, for being with us. I'm sure people have questions.
Yeah, Karthik, that was fantastic when Madam spoke about these early and late sequelae. We obstetricians, Madam, have got this, this tendencies inborn in us, passing the buck. Then a decisions at 25, 26, and those borderline weeks becomes very decisive. So
Very
that's
true.
the time we have to really use your head and say, should we not? Are we trying to do justice? Just a peri-viable record of some tertiary care hospital in the cities of India is showing record. That is for that one patient. What about the others?
I totally agree with you. I think that
Oh,
point is
nice.
very
Right.
well taken, that every extra day, like Dr. Sheetal said, is 2%,
2%.
improvement in outcomes. So I think
Yes.
that is really wonderful.
So that decision to deliver is very, very crucial.
Is very critical.
And another thing which we tend to disregard is the neurodevelopment issues in the babies. And after delivery, especially preterms and the IUGRs, there are specialists available. There are occupational therapists who specialize in looking at these babies and treating them. So if we involve those specialists in the treatment of the preterms and the severe IUGRs, their overall improvement in the terms of neurodevelopmental improvement will be much better. And we also need to involve psychologists who assess the neurological development, because if you talk to psychologists, they tell you that the LD or the ADHD or the other issues are picked up much later in childhood. If they were picked up earlier, then the child would not suffer. So it needs to be a comprehensive care that we need to provide. Manoj.
Yes, that's it. That's the way to go. I think it's an eye-opener. The entire session with Madam has been, as you rightly said, Karthik, eye-opener for all of us. A lot of introspection and decision-making. As you said, promotion of lactation becomes perhaps the thing which is still not, I've been seeing, it is still not gone that momentum which it deserves to get. It's sad. It's really sad. It's really sad to see. But anyway, I hope things change. So with the good future ahead of us, let's take a call on this webinar which we've had. 3 excellent talks, 2 good presentations. So on behalf of AFG, I think there are, because we have not received any questions from the chat box, Karthik, have we? Because
I don't know. We don't know.
Nothing in the chat. And whatever is there is not there mentioned. Yeah?
Okay, we have a separate link, so we don't know what the questions
don't
are.
even know whether anyone's listening to us, excepting those who are here.
I'm sure people are listening, but we'll find out in retrospect. As we said, the proof of the pudding is in eating, so we'll find out. So it's the outcome which matters.
A lot of thanks to the faculty. We had Dr. Geeta Balsarkar in absentia, so we'll thank her in person and on the phone call. Thank you, Madam Monkar, for making it possible. Always a pleasure to listen to you with so much of experience over the years. It's really a delight to listen to you. And of course, Shetal. Shetal, you've been a good thing for us.
The star of the show.
Yes.
It temporarily built up, it just went off. And suddenly, when I, let's be honest, we almost felt we were going into a lackluster seminar, this webinar. But then we zoomed off from there and everybody got activated with a lot of questioning. Thank you so very much, all of you.
Thank you so much.
It's a good time to have your lunch. I think we've not delayed your lunch for too long. Let's hope and we meet you all in the future. Thank you very much on behalf of AFG and Dr. Nitin Shah, our president. Thank you all for making it possible. Thank you very, very much.
Thank you.
Thank you.
Thank you. Thank you so much.
I forgot to mention Clarinet. Thank you, Clarinet.
Yes.
We can't do without you.
Now she will end the program.
Swastika, thank you very much. Please convey our thanks. Without you, we people really will have a tough time. Thank you very much.
Swastika, we can end the program now.
Hello.